kindly raise your hand if you wish to speak. Everyone who does wish to contribute to any of the issues that are under deliberation will be given that opportunity, but kindly respect the speakers on the floor or on the platform by ensuring that you raise your hands. I'd also like to welcome the staff members of the South African Human Rights Commission in the Eastern Cape Province. I'd also like to welcome all of the representatives of all government departments that are present this morning. I'd like to also welcome everyone who is joining us online. I'd also like to welcome members of civil society who have traveled from far and wide to join us this morning, particularly those who do work in the areas under discussion. Thank you so much to all of you and welcome. Colleagues, we convene today under solemn and urgent circumstances. The Commission has issued subpoenas in terms of Section 15 of the South African Human Rights Act to the heads of departments of social development, of health, of basic education, of home affairs, the Treasury, as well as the Office of the Premier in the Eastern Cape. These subpoena hearings follow the Commission's provincial inquiry into the right to food and child malnutrition in 2022 and the tabling of the Commission's malnutrition report in Parliament in 2023. The report highlighted the structural causes, including poor interdepartmental coordination and insufficient child support grant, lack of early nutritional programs in ECD centers, which is early childhood development centers, and failing food security programs. Despite the clear recommendations contained in the report, implementation has been slow, it has been fragmented, and it has been inadequate. In some instances, there has either been no response or the submitted responses have clearly been for purposes of malicious compliance. These ongoing failures, colleagues, constitute a direct violation of the fundamental rights, particularly those rights contained in Section 28, every child's right to basic nutrition, Section 27, the right to sufficient food and water, Section 10, the right to dignity, as well as Section 11, the sacrosanct right to life. The purpose of this hearing is not symbolic. It is to demand clear answers, to secure accountability, and to compel the development of concrete implementation plans to protect the fundamental rights of children in this province, but also in the country as a whole. Our Constitution recognizes the right of everyone to sufficient food and water, and the special rights of children to basic nutrition, to shelter, and to health care services. These rights are not aspirational. They are binding obligations on the state. They are among the clearest signals that the democratic project sought to reverse the long shadow of colonial and apartheid rule. These are systems that entrenched hunger, dispossession, and malnutrition as deliberate tools of subjugation. The Commission's National Inquiry into the Right to Food and Child Malnutrition concluded in 2022 with disturbing revelations of the reality, such that between 2019 and 2021, public health facilities in the Eastern Cape recorded over 1,700 cases of children admitted for severe acute malnutrition. Further to that, investigators confirmed that many of these deaths occurred despite children being... We are hoping everyone who is here is not lost. So if there's GPS signal that is lost. Investigators confirmed that of the children who did die, these occurred despite the children being in contact with the health system, meaning that they were not missed but failed. They were failed by weak systems of care. The deaths of children that have occurred as a result of malnutrition are not acts of fate. They are not natural disasters. They are the result of policy failures, systemic neglect, and the absence of coordinated state action. Since that inquiry in 2022 and its release in 2023, recent reports confirm that in 2024 and 2025, children are still dying of hunger in the Eastern Cape. This is 31 years after the end of the apartheid system. And this is a profound indictment. It speaks to a widening gap between the constitutional promise of dignity and equality on the one hand, and the lived experiences of our most vulnerable citizens on the other. The Eastern Cape stands as a painful symbol of a shameful national crisis. Despite social grants, despite policy frameworks, despite oversight structures, children are succumbing to preventable malnutrition. It is estimated that nearly 1 in 4 children under 5 in the whole country is stunted due to chronic undernutrition. In a country with middle income resources, endless green fields, and sufficient, albeit mismanaged water resources, this is unacceptable. The Human Sciences Research Council's National Food and Nutrition Security Survey, which was published last year, showed that in this metro, 40% of children were stunted to some degree, with 14% being diagnosed with severe stunting. Let us therefore be very clear that this hearing is not just a procedural formality. It is a matter of life and death. The Commission has called all of the departments that I have mentioned because the failure to act is violating the children's rights every day. The heads of department present today carry both the constitutional as well as the moral responsibility, Sheng. We expect from you not evasions or generalities, time-bound plans. How will food insecurity be alleviated at household level? How will coordination between departments be strengthened? How will budgets and resources be aligned to protect children? And how will accountability be ensured when obligations are ignored? The Commission wishes to remind all who are present that these hearings proceed under the authority of the law. The subpoenas issued compel your full cooperation, failure to comply with the constitutional obligations is not only an administrative shortcoming, it is a breach of the rights of children and a betrayal of the democratic project. Today, we remember how hunger was used as, but we also look forward with determination to ensuring that hunger is never normalized in a democratic South Africa. We cannot allow the promise of 1994, which is the promise that every child will be able to live, to grow, and to learn in dignity, to be betrayed by neglect and inaction. This hearing is therefore conducted with the utmost seriousness. We expect nothing less than accountability, urgency, and commitment to implementation. The children of South Africa and their right to food, health, and dignity demand no less. I now hand over to the provincial manager to walk us through the proceedings of the day. Thereafter, Commissioner Makwasha will lead us in the swearing in and the admission of the departments present. Thank you so much. Over to you, PM.
Thank you, Chairperson. Thank you, Commissioner Makwasha. I'm not going to be long. I think Commissioner Ntuli has captured exactly the purpose behind the proceedings today, and we do thank everyone who has made their way here today. We're looking forward to fruitful deliberations, and in terms of the outline of the program, the Department of Health will be providing us with their presentation first this morning. They are represented here by the Director General, Dr. Sandile Buthelezi, as well as Dr. Wagner, who is the HOD of the Department of Health here in the Eastern Cape. The proceedings will entail then a very active question and answer session then from the panel members based on the presentation that will be delivered here today. I would just like to make two comments before I hand over to Commissioner Makwasha. The first is that all participants just be aware that the proceedings are currently being live streamed. This allows for transparency and also for participation of members of the public. They are also able to comment and raise questions throughout the proceedings, which our office then actively engages on if there's any questions for clarity also from members of the public required. And then secondly, that the submissions are also going to be made under oath. With that being said, and also encouraging you to participate freely, it's not an accusatorial process, it's a very engaging process. Commissioner Ntuli has made it clear this is a constitutional duty for the Human Rights Commission, a process on which we are embarking on, or continuing with rather, a process that we started with a few years ago already, but from specifically the Eastern Cape's theme for the year. It is moving from recommendations to reality, and that is why we are here today. So with that being said, Commissioner Makwasha, if I can hand over to you. Thank you.
Thank you so much to the chairperson for outlining and reminding us why we're here, to Dr. Takata for just providing us the purpose of today. I want to start with the Department of Health. I just want to know who will be making the presentation. Can you just, for the record, just say your name out loud? Can we get him a mic, please, if there is an extra mic? Please do.
My full name is Sabelo Sandile Siyabonga Buthelezi.
Thank you, sir. Are you going to be taking an affirmation or an oath?
An oath.
All right. Do you swear that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? If so, raise your right hand and say, "So help me God."
So help me God.
Duly sworn in. Is there someone else who's also going to be making additional presentations?
Yes.
May she also stand and then take the oath? You may sit, Dr. Buthelezi. Thank you. Full names for the record.
Good morning. My name is Dr. Rolene Wagner.
Are you going to be taking an oath or an affirmation?
I'll take the oath.
Do you swear that the evidence you shall give will be the truth, the whole truth, and nothing but the truth?
I do.
Please raise your right hand and say, "So help me God."
So help me God.
Duly sworn in. I'm handing over to the panel just to provide guidance. Maybe I'll hand over to the chairperson.
Thank you very much, Commissioner Makwasha, and thank you very much to the representatives of the Department of Health. Welcome once again. We will now hand over to yourselves in terms of the notice that was issued to you. You were requested to provide us with certain information. We are aware that you have also submitted a presentation which will guide your submissions this morning. We will now give you the opportunity to present the report, and thereafter the panel will engage with you. Thank you so much.
Thank you very much, Chairperson, Commissioner Nduli, and all the commissioners present here today. And may I bask on the protocol that has already been established. I'm not sure if we will have the presentation beamed. Oh yes, thank you very much. So I don't know if we can move the slide to the next slide. I'm not sure if the copies were sent to the commissioners because they are there facing the, oh, thank you very much. I think the background has been established very well by the chairperson, so I will not waste time on this slide because it was well covered how the report came about and was presented to Parliament and what was picked up on that report. We can move on to the next slide. I think here I will touch on a bit specifically on what we've been requested through the subpoena. We have been subpoenaed specifically to answer a number of questions. The first one is a current number of child deaths due to severe acute malnutrition, disaggregated by province with emphasis on the Eastern Cape. Number two, an analysis of causes of these deaths, including systemic, health system, and socio-economic factors. Number three, identification of hotspots in the Eastern Cape, in brackets districts, municipalities, mostly affected by child malnutrition and related mortality. Number four, updates on severe acute malnutrition interventions, child mortality audits, and health system strengthening. Number five is budget allocations and timelines for nutrition and health programs addressing child malnutrition. Number six, intersectoral strategies with different Department of Basic Education, Department of Social Development, and other departments to address child hunger. My apologies, I did not acknowledge my colleague DG from DSD who's sitting behind me. All supporting documents, policies, mortality statistics, internal reports, and monitoring frameworks. Can move on to the next slide. And we have structured our slides according to questions. The first slide is looking on the current number of child deaths associated with severe acute malnutrition. Before going on to this slide, since the report came in 2023, we've been able to get data for the whole of 2024 and then the data for 2025 up to July. The data here is that the data source is the system that we use, which is called the District Health Information Systems. Now, why I mention this is that that means it's the children that are recorded in the facilities, be it clinics or hospitals. There might be those who die outside of our hospitals. There might be those who die in private hospitals. And currently with the systems that we are working on, the private hospital data, we will be able to start getting it on very soon. But for now, this is just the public health facilities. But also there are those that die in communities. And that data we normally get through what we call South African Demographic Health Survey that we do almost every 10 years. We're actually behind. We've just finished budgeting for it now. It was last done in 2016. So that data might not be reflected because it's not accurate. So in terms of the DHS, in 2024, the data that we have and is verified is that we had 573 deaths that happened in South Africa. with KwaZulu-Natal leading at 117, Limpopo at 112, and the Eastern Cape at 107. So Eastern Cape was ranked number 3 in terms of the DHIS data that we have. What is very worrying with this data is the discrepancy, not really the discrepancy, the difference. If you look at other provinces as compared to the Western Cape, Western Cape is only the single digit and others are actually 3 digits in terms of the information. Now when we go to the data for 2025, which is up to July, so the year is not complete, Western Cape, my apologies, Eastern Cape has already recorded 70 deaths as at the end of July. If you look at that and the 107 they recorded last year, they might get into the same number or maybe slightly higher if you look at the trends up to July. But other than that, we've broken it down to throughout the other provinces in terms of the numbers. Again, it's still very clear if you look at the Western Cape, the numbers that they've recorded, that it is still problematic. But Limpopo and KwaZulu-Natal are really starting to worry us, which shows that this problem is not really a localized problem in the Eastern Cape, but also in the other provinces. We may move on to the next slide, please. What we then did as requested, we then did a deep dive into the Eastern Cape, into the districts in the Eastern Cape, and we can see here that the very worrying district is Nelson Mandela Bay in terms of the numbers for 2024, followed by Alfred Nzo, Amatole District Municipality, and then Oliver O.R. Tambo District Municipality. The district with the least number is Sahrc, and we don't know whether it's because also it's mostly bordering the Western Cape, if I'm correct in terms of my geography, Dr. Wagner. So it's really recorded very small numbers as compared to the others. And the bigger worry is with Nelson Mandela Bay, it is actually an urban district, mostly an urban district here in the Western Cape. We'll then move on to the next slide. Can we, someone who's moving the slide, please help me. Then we move on to the second question in terms of the socio-economic factors in terms of the causes of death. In general, child deaths are linked to malnutrition, are deeply rooted in the socio-economic inequalities that persist across communities, particularly in rural and township areas. Many households face chronic food insecurity, lacking regular access to safe, sufficient, and nutritious meals. This is compounded by high poverty rates and unemployment. We also have structural issues such as substandard housing, environmental hazards, and lack of access to basic services such as water, sanitation, education, and health exacerbating vulnerability, which actually restrict caregivers' ability to provide adequate nutrition in early childhood. I've mentioned the issues of environmental hazards. South Africa have gone through a very difficult task where we've had foodborne deaths due to what we call organophosphates, such that we had to put a special ministerial advisory committee put by the president, because the president had to address the nation because of those deaths, and we've had to recommend the banning of terpiphos, which is an agricultural organophosphates, because that's what has actually been killing children. Actually even worried us, I know this might look irrelevant, what has been worrying us is that these kids, they go to these buzzer shops and buy these snacks and all of that, which were actually laced with these organophosphates. But what even worried us more, that this group of different specialists told us that those deaths that we saw in Naledi were actually a tip of an iceberg. Actually in Cape Town, they'd actually done a study to do the postmortems, and they've picked up a lot of kids who have died in the previous years, and they've picked up the particles of terpiphos within their gastric lavages or their gastric juices. So the next one, that is children in low-income households are more likely to be stunted, underweight, and or even overweight due to disrupted eating patterns and poor dietary diversity. So the issue of the current economic situation in the country, with poor economic growth, job losses, reduced household income, intensified challenges forcing families to choose between nutritious food and other essential expenses like rent, electricity, paying for education, paying for health, which is why, by the way, we need the NHI. These socio-economic factors, combined with inadequate childcare support and limited multi-sectoral coordination, contribute significantly to the high rates of malnutrition-related child mortality in South Africa. We can move on to the next slide. Then, in terms of socio-economic factors, the General Household Survey done in 2024 shows that although the percentage of households in the Eastern Cape with access to water in the dwelling and in and off-site, whether in-house or off-site through the community taps, increased by 23% between 2002 and 2012. Access has actually declined recently to almost 69.9% since then, which is very worrisome. Grants were notable more prevalent than salaries as a source of income in the Eastern Cape. Actually, according to this study, 65.6% people were dependent on grants as compared to 49% who are dependent on salaries. Furthermore, 31.2 households reported inadequate or severely inadequate access to food in the Eastern Cape, with Nelson Mandela Bay reported amongst the metros mostly affected at about 33.4%. Poor infant and young child feeding practices, especially low exclusive breastfeeding, where the parents will, especially the young ones, will get the kids and then leave them with the grannies at home, and they are unable to do what we call exclusive breastfeeding, which is proven scientifically that it improves the nutrition of the children. So for us, that is one of the issues that is really quite problematic. But we also do see kids that are now being overweight, which is also a malnutrition in itself, being overweight, because it affects the health of a person. Can we move on to the next slide, please? Then, in this slide, mainly what we're talking about is that malnutrition per se does not kill, but it predisposes it. It's a contributory factor. It's like HIV. HIV normally does not kill a person, but it makes your immune system worse. Then you die from TB, you die from meningitis, you die from toxoplasmosis, you die from any other issue because your HIV has weakened your immunity. So it's a contributory factor. So 6 of the districts that have submitted data on severe acute malnutrition that's collected through the mortality audits, which we've provided an annexure. We record that firstly, as when we are able to assess the nutritional status of each child that is admitted, whilst some of our clinicians record these children to have died from severe acute malnutrition, but it's mainly due to complications, and mainly those causes are issues like diarrhea, some of them dying from TB, some from shock, from cardiac failure, from congenital illnesses and other illnesses that are exacerbated by malnutrition. So it's mainly a contributory cause because it also cuts the immunity of those babies so that they are exposed to other diseases like as mentioned, and that for us is really a serious worry. But what is more problematic for us is that in the department we get involved when these kids present when they are already very sick. It is very late, which we're going to talk about that. We are down in the value chain in terms of picking up these kids, and sometimes, as mentioned, the commissioner did mention that it's not a fate, but because we are all government and we are all of society, so we need to take responsibility for this. Next slide, please. Can someone help me with the next slide? So in terms of the health system factors, between January and September 2023, the Department of Health at National, in collaboration with UNICEF, which is the United Nations Children's Education Fund, undertook a malnutrition bottleneck analysis in selected districts in the Eastern Cape, in Gauteng, in KwaZulu-Natal, and Northwest provinces. The purpose of the analysis was to assess barriers to coverage, uptake, and quality of acute malnutrition and maternal nutrition services targeting children under 5 years and women of reproductive age. The analysis showed that there are key bottlenecks in the delivery and uptake of quality of both maternal and acute malnutrition services. I will mention why we keep on referring to maternal and the malnutrition services. The gaps identified range from the specific bottleneck in both the supply and demand of services. These include gaps in meeting the staffing norms to deliver efficient quality services, lack of adequate capacity building of the healthcare workforce to deliver services, barriers to geographic access to services, stock outs of essential commodities required for screening and management of acute malnutrition and maternal nutrition services as well, gaps in the initial and continuous utilization of services by pregnant women and mothers of children with acute malnutrition. The nutrition program in the Eastern Cape has actually some limited staffing, just like any other provinces, because of the fiscal constraints that we're facing as a country. So it's one of the areas, but we've provided that as an annexure in the report, just with more detail. We can move on to the next slide, please. So in terms of the hotspots in the Eastern Cape, these hotspots were actually identified in partnership with the teams from DSD, and thanks to my colleague, Mr. Nancy Pale, the DG, because there is quite good working together, where actually these hotspots are based on household food security. And per district, we've put them in Atfrednzo, Matatiele, Mbizana, Mount Frere, Mount Elif, and then Amatole is Muma, Jokabi is, my eyes are failing me, I don't know if I can open. Apologies. Thank you very much. Jokabi is Elundini, and Buffalo City is King Williamstown, and then they've also put in the specific village just to zoom in those areas. And surprisingly also here in Buffalo City they've got East London, which is mainly the town area. Then in Nelson Mandela it's Nelson Mandela Metro. In Sahrc is Kucha, Grafreinet, Blue Crane, Makana and Lambe. Then I won't mention the actual villages. Then in Krisani is Engobo, Tofimbaba, Komani, Queenstown, Craddock. In Ortambo is Imuza Hill, Nyandeni and Point St. John's. Next slide please. We'll then answer question 4, which is the key activities to address national interventions. Routine implementation of evidence-based interventions aimed at prevention, early identification and treatment of severe acute malnutrition, and these interventions are included in all guidelines that outline the care that should be provided to children at community, primary health care levels and hospital levels. Now I've mentioned the issue of maternal health. That's what I'm going to talk about. Now preventive interventions are contained in what we call the first 1,000 days package. This is from conception, because if the mother is not getting proper nutrition from conception, actually even pre-conception, but for us we concentrate on the first 1,000 days of life. Both in utero and outside of the uterus. So this, we have a very clear documentation on this. Actually, there have been a number of presentations that if we want to improve this in future, we should actually be considering a particular grant for pregnant women that are vulnerable, so that they get proper nutrition even when they are still pregnant. But we also then have treatment guidelines, which include integrated management of childhood illnesses, integrated management of acute malnutrition and essential medicine list, standard treatment guidelines for primary health care. All this is already too late, because you're already dealing, once you talk treatment guidelines, you're talking about a person who's already presented to the facility. Scaling up of community-based screening for acute malnutrition, which include involving the caregivers at household level to improve detection. We use community health workers to conduct tracing and tracking of all discharged children with severe acute malnutrition, and also follow them up on discharge. We have just more than 45,000 community health workers as a department throughout the country who are properly trained on this. Continuous capacity building of frontline staff in the management of children with severe acute malnutrition. We can't just assume that someone, just because someone has got an MPCHB or has got a diploma in nursing or a degree in nursing, some of these things you learn, and medicine you learn every day, and things change every day. I mean, we sign new guidelines every day based on evidence that comes in, so we need to have this continuous capacity building. Data verification and use of data for action at all levels of care. Because when we have this data, for example, here we have the data, we know where are the hotspots. How do we work with social development to get into those hotspots and ensure that there is food security, but also and screen the babies at that particular level. Then, of course, implementation of targeted operational plans based on malnutrition or clinic analysis conducted in the selected districts. In terms of question 4, looking at key activities to address them at provincial interventions, the Eastern Cape province sponsored by UNICEF, there were workshops that were facilitated by National Department of Health where we're training people on the use of registers, data verification and classification of child malnutrition. And the aim of the workshop was to significantly reduce data reporting discrepancies for severe acute malnutrition, pneumonia, and diarrhea performance indicators on the DHIS. The workshop targeted 218 clinicians, which are doctors, dietitians, integration nutritionists, program managers, and different healthcare workers. The Department of Health also formed part of what we call integrated community registration and outreach program with the aim to collaborate with other departments and NGOs. This initiative is continuously implemented to support provision of services aimed at reducing child malnutrition. The department also collaborated again with UNICEF to conduct a workshop in Johannesburg aimed at capacitating provincial nutrition managers on estimation of malnourished children and forecasting of stock required for the management of children with acute malnutrition. When we come to the 25 to 26 financial year in the Eastern Cape, workshops on early childhood development and health workshops were conducted at OR Tambo and Buffalo City municipalities. These workshops targeted cadres from Department of Health and Department of Basic Education. The aim of the workshop was to strengthen collaboration between this department in addressing child health and nutrition programs in ECD centers. As the Honorable Commissioners are aware that this year is the first year that a grade R is actually compulsory. Hence, we've also started a very strong program of screening all the grade R children. We've just screened more than 96,000 of them, and we focus on nutrition, vaccination status, eyesight, oral health, and hearing mainly, but in any other issues that they pick because they are entering now at the first at that particular level. In the Eastern Cape, a contract for procuring feeding pumps, tubes, and related consumables has been secured so that there is efficient delivery of feeds, specifically the enteral feeds, to those that are admitted. That means the feeds that are either given through the drip or through the nasal tubes that we use. Also in April 2025, representatives from all districts were actually inducted from the 8 districts here on the integrated management of acute malnutrition guidelines. In June 2025, there were 2 inception workshops that were conducted at OR Tambo and Nelson Mandela districts, and they were done with UNICEF. UNICEF actually, after this report, has been very active in supporting specifically the Eastern Cape in a number of activities, even in the training of what our ward-based community outreach teams, which are mainly community health workers, in even training them of what we call the MUAC. MUAC is what we call upper arm circumference, a very easy way that is used for community health workers to see if the baby is starting to have some signs of malnutrition. Then we've got a slide on the budget, mainly in the Eastern Cape, which has been put there, but the total is about 21 million, but it covers mainly the milk banks. The other budgets are actually integrated into primary healthcare budgets in the clinics, but they are specifically reserved budgets that are to assist mainly with the milk banks and specific interventions, and it has been put there per districts. In terms of intersectoral actions, as I go towards the end, the National Department of Health actually supports the implementation of nutrition-sensitive intervention led by key sectors, namely Department of Social Development, in terms of social protection measures, including social relief for the distressed and the child support grant provision of meals within the community, nutrition development centers for the vulnerable population groups, including children. The National School Nutrition Program, led by the Department of Basic Education, which feeds the children. Department of Health actually is involved in even approving the diets that should be there and ensure that those are properly drawn up. Agriculture in terms of strengthening food systems to ensure access and availability of nutritious foods. So collaboration with key food sectors in the revision of the National Food and Nutrition Security Plan, which has just about a year ago, has just actually expired. It is currently being revised to have the next strategy, which is aimed at addressing all forms of malnutrition, hunger, food insecurity with consideration of the lesson from the evaluation. We sit in the same cluster with the DPE, DSD, the SPCHD cluster, the easiest to say is the social cluster, and health, and we actually co-chair that cluster, and we meet every month just to go through these policies so that the relevant departments actually participate. So at a provincial level, the Department of Health has joined an intersectoral collaborative group comprising of the Department of Social Development, SASA, Home Affairs, Education, Agriculture, COCTA, and the National Development Agency. This department participates in the Integrated Community Outreach Program, ICROP, which aims to reach the poorest wards and provide essential services. In 24-25 financial year alone, a total number of 43 ICROP activities were conducted across all districts, and actually more than 80 malnourished children were actually identified. In the current financial year, 52 have been done to date. There is a critical need to strengthen ICROP activities at a sub-provincial level, that means at a district and a sub-district level, to ensure effective situation analysis, improve linkages between departments and partners, as well as robust monitoring and evaluation. A central electronic system to monitor service linkages and outcomes is also urgently required. The University of Fort Hare has presented a concept proposal, and there are discussions specifically to see if how that can be funded, so that at least we have a system at a central level to monitor this electronically rather than depending on manual reporting system. In addition, the department actively participated in development of food security and nutrition plan, and a final draft plan has actually been submitted to the coordinator for the SPCHD cluster here in the province, which is the social cluster at the easy term that we normally use. So in summary of implementation of recommendations, is to explore the feasibility of in terms of exploring the feasibility of establishing nutrition-focused early childhood development clinics in partnership with the DSD in providing regular checkups, growth monitoring, and nutritional counseling for children under 5, particularly in vulnerable communities. Services are provided within primary healthcare facilities. Ward-based outreach teams conduct community-based screening for acute malnutrition, including involving the caregivers at household level to improve early detection. Workshops are held to strengthen collaboration between Department of Health, Department of Social Development, and Department of Education addressing child health and nutrition programs in the ECD centers. Following the workshops, all districts developed plans on rolling out intersectoral collaborative interventions going forward. In terms of the exploration of the development of a comprehensive program for the early identification and treatment of malnourished children, including provision of therapeutic foods and medical care with focus on severe acute malnutrition, all health facilities provide the appropriate package of care aimed at early identification and treatment. Community-based services provided by our community or ward-based outreach teams and at SED centers, these also are being strengthened so that we are able to pick up these kids outside of health facilities. Therapeutic feeds are available in all health facilities. Yes, we do have ongoing challenges regarding facility level ordering, but district and provincial managers, they monitor stock levels and intervene when necessary. In terms of immediately make available data to NGOs upon request, which may allow for targeted interventions and assistance in respect of food and of food aid and supplements in specific wards and communities. The DOH has made data available, and hotspot areas have been jointly identified in collaboration with the Department of Social Development. The reports have been submitted to the Commission. We've submitted them, and we want to ensure that the quality is what is expected from the department. In terms of our own recommendation, the department will continue to strengthen the interventions aimed at 1, preventing severe acute malnutrition and improving infant and young child feeding through implementing the first 1,000-day package of services which includes nutritional support for pregnant women, promotion of breastfeeding, nutritional education, and growth monitoring and support as outlined in the Road to Health booklet. Secondly, by strengthening early identification of acute malnutrition at household and community levels through capacitation of ward-based outreach team members, ECD practitioners and caregivers, ensuring that children with severe acute malnutrition are treated in line with current guidelines, including the provision of therapeutic feeds. Second, ensuring that young children from food insecure households have access to nutritious food is important, and it remains a challenge and it requires interventions outside and beyond the health sector. It is recommended that the school nutrition program be extended to all the ECD centers, not only start within the schools, because sometimes it's too late when it comes to them to start grade R. So it's one of the recommendations that we are putting in. Second is that there's still some ECD centers, especially in under-service areas, that are not registered and are not receiving subsidies. And it's one of the areas that we need to look in, because they still cater for a number of the children in that areas. I know my colleague won't be happy with me, but the child support grant is one of the most targeted grants that is there in terms of looking after children. Actually, it's the grant that we should really consider to strengthen because it's a very targeted grant. Then we've put in a number of supporting documents. I'm not going to go through them, but they were all requested and they are annexures to this presentation. And on this note, I want to thank the honorable commissioners. Don't know if they would like my colleague to come in now or to come in during the question time. Thank you very much.
No, thank you very much, DG, for your presentation. If your colleagues do have something to add at this stage, they are at liberty to do so.
Good morning, Honourable Commissioners. Good morning to the DGs and the colleagues in the room. At this stage, we've given all of our information to the DG and he's presented it, but I am available to respond to any questions you have specifically aimed at the Department of Health. Thank you.
Thank you, HOD. Much appreciated. Then DG, I will hand over to the panel to engage with your presentation. I'll start with the provincial manager on my right and thereafter Commissioner Makwasha on my left. PM.
Thank you so much, Chairperson, Commissioner. Thank you so much, DG as well as HOD. This information is really helpful. It does create a foundation and a baseline for us to engage from for the rest of these proceedings. It is also a very sad way of opening the day, indicating that in 2024, 573 children died because they were hungry. And if I listen to you correctly, DG, that these are preventable deaths. But I'm also listening and looking at your presentation, DG, and I'm also seeing that these are perhaps very underreported as well. And I can see you nodding, DG, just for the record there. My first question relates to, and I'm going to pose a few questions perhaps, Chairperson, and we can allow the DG to answer and then we can perhaps hand over. Thank you so much for the direction. In 2021-22, the number of deaths recorded in the Eastern Cape was 116. In 2024, you've presented that the number of deaths we are presenting is 107. Now, DG, my request to you and my question to you is, would you agree that that is not a remarkable decrease at all in terms of the preventable deaths? Why I'm asking you that question, DG, is because we will be hearing from all your stakeholder departments about the programs that they have been implementing throughout the past few years. And I want us always to go back to this number of 107 deaths and a projected increase, perhaps, in the 2025 numbers as well. So I want your comment on whether that you view this as a decrease. Am I still on? Am I still on? All right. in respect of the efforts that we will be hearing from the stakeholders here today. I am very excited that you have echoed the recommendations the Human Rights Commission made in our malnutrition report a few years ago, that the child support grant is falling under the food poverty line and that it is a very targeted effort and response, a successful method in addressing child malnutrition. You've also agreed here today that the ECD sector needs strengthening in accessing school nutrition program. You've agreed to that here today, DG. But I want to ask you in terms of the severe acute malnutrition audit analysis and the deaths relating from that. Your analysis, does it indicate and analyze whether these children died with birth certificates? Did they have birth certificates? And also, these deceased children, did they have access to the child support grant? So those two pointed questions. And then just thanking you again for your submission and echoing what the Commission through its monitoring process has picked up, that despite our report from a few years back already, 2022's inquiry, and despite us acknowledging, and I want to make that categorically clear, the efforts this province has put in place, we acknowledge that final draft of the strategy remains unsigned. And perhaps to ask your comment on that, because in our view, and looking at the numbers of 107 children still dying, and we're looking at an increase in unemployment rate, are we moving the needle, DG? Are we moving the needle? So, Chairperson, with that, I'm going to hand back over to you.
Thank you very much, Provincial Manager. DG, let me give you the opportunity to respond to these questions before I hand back to Commissioner Makwasha.
Thank you very much, Honorable Commissioner. I would be very pointed before I give over to my colleague, Dr. Wagner. I think we did acknowledge that the numbers are underreported because it's only facility-based data. There is data that happens outside of our facility, so the numbers are actually not the actually accurate numbers that we should be dealing with. 116, 107, numbers don't lie. That means we're not moving the needle. Whatever efforts that we've been putting, it's not giving us what we want as we move forward. But I'll allow my colleague to comment on that one. And then I think I might not have the answer, maybe my colleague will have the answer in terms of the mortality audit if they had birth certificate or they had access to the child support grant. I will not have accurate data in terms of that. The final draft of the strategy, I will allow my colleague in the province to comment on that one. Thank you very much.
Thank you very much for the questions, Commissioner. I also just wanted to comment on the drop. You're correct, a 116 to a 107 drop is around 7% across those numbers of years. We've looked at the first quarter number of deaths associated with severe acute malnutrition, and in quarter one it was 20 to 37 the prior quarter. For those who are familiar with continuous quality improvement, we would need a couple more quarters on a downward trend before we'll be confident that it is on a downward trend. But we have observed that with the improved coordination between departments, it appears on a month-to-month basis to be coming down. As our DG has said, if I may talk to those statistics, our role as the Department of Health in the Eastern Cape, we start by just looking at the causes of death. And as our DG has said, often severe acute malnutrition is not the cause, it's an underlying cause. And the children are dying from TB, HIV, infections and so forth. So once we've analyzed what the causes are, the other key component, as DG said, is to analyze where it's occurring. Because when you've got limited resources, you want to make sure that you are directing those resources at the right places in order to have the desired impact. So in our department, we've actually focused on on active case finding through our community-based outreach teams. We've actually increased the number of community healthcare workers. So in last year we had about 3,843. This year we've got 4,050. And we also have just under 600 community healthcare workers in our NPOs. So that's just within our own department. And we've increased the numbers of households that we were able to reach in the last year in order to try and find these children. And as our DG was saying, the other big drive of ours is to capacitate our community development workers on identifying children who are at risk and then linking them to care. The other very important thing was, as our DG was making the point, that early childhood development is a very important phase for us to tackle. So we have had capacitation workshops with the Department of Education as well as the Department of Social Development, and we think that these are some of the contributing factors to why we may be seeing the decrease, because we are identifying children in order to link them to care, particularly at our early childhood development centers. It is still early days, and as I said, we would want to see a continuous decrease month to month and quarter to quarter to be confident that we are on a sustainable downward trend. But those are some of the interventions that talk to some of the patterns that have been observed. The other thing I thought might be useful, and it's linked to what you were speaking about, is we treat the situation holistically. So the Commissioner is correct. Poverty obviously impacts your ability to access care. And when we looked at the causes of death, we realized that often the moms are seeking care late. And so by the time they come to our facilities, they're already in extremis. So yes, it links to us finding these at-risk households and the children at risk. It also talks to how do we promote access and transport for vulnerable households. And because we know transport is a challenge for the vulnerable households, as government we've been doing the outreach services and increasing the outreach services. And our DG did emphasize how in last year it was about 42 outreach visits, I'll just confirm the facts. And there we identified 80 children who were malnourished, and we could now link them to care and make sure that they become part. I would say in a way, DG, we could say that those 80 children were preventing children from potentially being at risk of dying with complications associated with severe acute malnutrition. So we are starting to see some benefits from this integrated way of how we are working. Our Premier, I'm sure, will talk when they appear before the Commission. They will talk about how we've taken all the different programs of government, the social programs that require other government departments to work together. They've organized us into 9 specific focus areas. It's called the integrated program, where we all work together around 9 key areas that require coordination between government departments. And as we say, these are early days, but we are encouraged to start seeing the improvement and the benefits of working in such a coordinated way. That being said, DG and Commissioners, I think there is an opportunity to strengthen what we're doing even further. And often when we work as government departments, we're dealing with a lot of information that can help us be even more targeted and make sure that when we do find someone, link them to care, that we follow them all the way through beyond the 1,000 days. And that is where there's an opportunity for big data to be utilized and AI to assist us in better allocating resources, and then linking the persons to the different government programs and ensuring that we're not missing, that there are no gaps. And as our DG said, Fort Hare has put together a proposal, and as the Department of Health, we are also exploring digital solutions to enhance and augment our available resources. Thank you. With respect to the strategy, it is led by one of the other government departments. When they appear, they will give you an update on that. But as the Department of Health, we've given input to the overall strategy. And even whether it's being signed or not, each of our departments have those programs in our annual performance plans, and we are implementing them. Thank you very much. I hope that answers all of your questions. Thank you.
Thank you, HOD. I'll now hand over to Commissioner Makwasha.
Thank you so much to the chairperson, and thank you to Dr. Carter for just setting out the questions. There are a number of questions that I have, and in preparation for this I went and I got the book that all those who are working in healthcare need to have in terms of children. So I'm going to be also making reference to this book. But I think that it's quite sad that on one hand the department is saying we have two issues of malnutrition, but under malnutrition we have severe malnutrition and then obesity. They are working and they indicate how, South Africa, we live in a very different society where there are children who have obesity and there are children who are malnutrition. Now, you spoke about the exclusive breastfeeding, and you're saying that it's an indication that it can improve malnutrition. But as I was reading the book as you were making presentation, and I'm going there, it states that there's no clear evidence that it actually does contribute positively to alleviate malnutrition. But speaking to that, you spoke about most of the reason why it is not a primary source of nutrition for children is because mothers are reluctant to breastfeed. And as I was noting your submission to the commission, you stated that most of the mothers are teenage mothers, so we have teenage pregnancies. Due to the lack of development for pregnancy, or due to, it says teenage pregnancy, teenage pregnancy was prevalent and poses risk for both young mothers and their infants due to their body's lack of development for pregnancy. The submission also noted that teenage mothers were often reluctant to breastfeed, potentially due to body consciousness or attending school. This had a negative impact on caregiving practices, and breastfeeding rates in the province were below 50%. My question regarding this submission, has it increased or is it still below 50%, given that we're speaking about teenage mothers? But have we also then educated teenage mothers on the importance of breastfeeding? Have we also then involved the grandparents of these minor children or infants who have now not been given breastfeeding as a result of the mother's subconscious? That's the first part. And then the high levels of vacancies, you did raise it again at the initial inquiry. Have you over the past 2 years had a program to decrease the high levels of vacancies, given the fact that this would essentially amount to a crisis within the healthcare facility? Because of course it does not just stop at 0 to 5, it impacts on children. I was quite interested in that a lot of South Africans are very short, and most of the time we just think that it may be a regional thing, but it could be simply due to malnutrition issues such as stunting. I would like to just congratulate you on the screening of grade R children, which is very important. It will also give you the data you would need. But is there training for the service providers in terms of the National Schools Nutrition Program? Is there training for those who will be then working with grade R children? Because it's very difficult to notice malnutrition. It may be just the child is very small, but it may be due to malnutrition. You spoke about the 80 malnutrition who identified and referred to health facilities, but what is the progress currently? Can we given numbers that given the intervention they have then improved in terms of their health? I think I'm going to then the last question that was raised by Eunice. I think this is something that UNICEF stated. It speaks about primary forms of malnutrition are in the country are Am I back? I think I'm back. Am I back? Am I back on? Yeah. Let's just. Thank you. Am I back on now? All right. Now, UNICEF in their presentation to the Commission stated that multiple factors contribute to child malnutrition, including limited access to nutritious food. It's not about access to food, because it's important the type of food they're having. And you spoke about how you provide training, and I just wanted to touch base on training to the service providers. As we're speaking, we noted in some ways that some of the service providers are unable to properly cook the food, and you say that you have an input on the can I say the menu, but you have an input on how it's prepared, how it's stored, that part. Inadequate feeding practices, poor hygiene and sanitation, and poverty. Have you, in terms of the role that you'd be playing in your interdepartmental relationship with other stakeholders, ensured that they understand the importance of those three key issues and how to prevent them? So those are my current key questions. Thank you.
Thank you, Commissioner. DG, we'll hand over to you.
Thank you very much, Commissioner. I'll leave most of them to my colleague here to deal with them. I'll talk about vacancies, because we actually have a national crisis, a problem. I mean, we all know, we watch TV, doctors are unemployed, nurses are unemployed, but what have we done? Through our minister and the National Health Council, we've deliberately approached National Treasury and said, look, because of all these problems, which are the health budgets have been going down over the years, so what would you be able to give us? And for the first time this year, we've had a positive response. I mean, the minister, because this was in his budget speech, it's known nationally that we've been allocated 6.7 billion as a country. And actually, we're waiting for that allocation now, and there's been an agreement that we need to the different provinces will appoint doctors, nurses, and additional. It's not going to make a huge dent, but it's a move in the right direction. But provinces are using different modalities to address those issues. I will allow Dr. Wagner to talk about that. But most of the things I would like Dr. Wagner to actually deal with them. Thank you very much.
Thank you very much, DG, and thank you, Commissioner, for the questions. And I'll start with where the DG ended with respect to the staffing levels in our facilities. So at around about August of last year, when myself and the new term entered office, we had a budget deficit of 900 million rand to cover the salaries of our warm bodies, in other words, people who were in our employer already. So we started, the reason for that deficit was related to budget cuts, as well as an underfunding of the annual increases from year to year from the preceding 2 years. And then we'd also taken on employment of our community service health professionals after they completed community service. As a result, in terms of the PFMA, we have to come within budget. So as posts were vacated, we were not in a position to replace those posts. And so, yes ma'am.
HOD, I'm going to ask that we just take a 10-minute adjournment for anyone who might need the bathroom. Sure. Thank you so much.
Certainly. staff, and I was explaining that we had started on a deficit in the province of around 900 million by August of last year to pay the salaries and benefits, and that was as a result of budget cuts as well as an underfunding of the annual increases year on year, and then we had made a commitment to employ our community service health professionals after they had completed the end of last year. As we're standing now, we are at what I would call a break-even point. In other words, we now have sufficient budget to pay the salaries of the staff that we have in our employ. We also, in this financial year, allocated in our annual recruitment plan to appoint around 721 different categories. When I say we're at the break-even point, it means that we can now defend that baseline so that when there are any people exiting the system, we're in a place now to do replacements. It came, unfortunately, at a very expensive cost to us department, because in order to meet our financial obligations and come within budget, it meant that we had to sacrifice posts, and that puts a huge burden on the staff remaining behind. So that's the staffing pressure that we have experienced. As our DG has said, the ministerial intervention now to bring in the 1,200 doctors, 200 nurses and 250 other categories will greatly assist the provinces in trying to close the gap. We do have a staff shortage with clinical support though in our facilities, so porters, cleaners, etc., and that tends to put a bit of pressure on our clinical teams who are also having to provide care. But it's a matter that we're dealing with as a sector. I want to talk then to the questions raised by the Honourable Commissioner around the issue of breastfeeding, exclusive breastfeeding. What we have observed is that when mothers do breastfeed, we're wanting to encourage mothers to exclusively breastfeed up to the age of 6 months and then to continue breastfeeding up until the age of 2 years. And it's in those circumstances that we find that the chances of developing malnutrition are reduced if the mother's well nourished and they're able to supplement the breastfeeding with other appropriate energy-rich foodstuffs. What we have observed now, though, is a trend where children under 6 months are presenting with severe acute malnutrition, which is a pattern that we didn't really observe as a significant issue before. And that points to what the Commissioner was raising. If you have a teenage mother, they, because of body consciousness or trying to hide pregnancies initially and the self-conscious potential social stigma that they feel, they do not breastfeed, or they go to school and they're not with the child during the day. So that is a challenge for us in our province. Teenage pregnancy, the way in which we're approaching it, you obviously want to prevent teenage pregnancy. But in order to prevent it, it means they must have access to youth-friendly services. So one of our key interventions has been targeting youth zones. We have over 400 youth zones. In the last quarter, we just had an additional 10 that have come online, and we have staff allocated there that are specifically selected and trained to make the services friendly for youth to come and access services. We've also provided a long-acting contraceptive option so that young people don't have to come in often, that they can have long-acting contraceptives. So overall, the total fertility rate in our province has decreased, but we still unfortunately find teenagers pregnant. And this has at its roots deep social issues that we are exploring, and we have endowments with multiple stakeholders. So there's one area of integration which focuses on moral regeneration, social determinants of health, and mobilizing communities to have discussions about what are the factors driving teenage pregnancies and how do we prevent that within the communities. We have also detected, and this is anecdotal evidence, that parents believe that contraceptives can make their children infertile. And so the children, the young mothers believe that, and so there's a hesitance to take up contraceptives. So those are the kinds of beliefs that drive behaviors that we need to analyze, understand the context that it's occurring in, and work with stakeholders to debunk any types of myths that may be pervasive. But it is an integrated approach that is required. With respect to the grade R learners and training, our DG reported the stats on grade R screening, and we can make those available to us, to the commissioners. The question that you are asking, though, is are we training the service providers? So as the health department, we've not trained the service providers to the school nutrition program, but what we have done is, together with UNICEF, we've had training with social development as well as Department of Education, and we've contributed to the strategy. So we've given input to menus, hygiene conditions, etc. At the training, we also invited environmental health practitioners. So once we did that centralized training, each district now carries out, it's the training of trainers approach. So in each district there are now plans being implemented by the districts to work with Department of Education, Social Development at a district level, sub-district level, so that everybody can be educated around how to provide nutritious food, how to ensure we store it safely, etc. So that is work in progress, and as the Health Department we have not been training the service providers themselves directly. With respect to the 80 identified So what we find is that when we find these children, they may be recorded on an Excel spreadsheet, which does not necessarily assist us in the bigger scheme of things to be able to track and trace them. And that is why I was saying earlier when I responded to Commissioner Carter, it's important that we have electronic systems to record information, and this is big data. We're talking about 6.5 million of the Eastern Cape population depend on public health services. So we need an electronic record system, but we also need to have the capacity to mine this rich data that we do have in the system and make sure that we can then coordinate and link to care. So that's one big opportunity that I believe will yield a lot of benefits in being able to give you assurances. As I'm sitting here, I cannot give assurance that a child X out of that 80, I know that they were linked to care, but we've not been able to track and trace them all the way through as I'm sitting here. I would have to go down literally to the level where it occurred, and that individual would have to be able to give the assurances that indeed they followed child X all the way through. So that's what we need to do as a province. If we want to ensure that complete cycle is completed, we need to analyze our data and create systems that allow us to track and trace end to end. I think I've covered all of the areas that was raised by the Commissioner. If there is anything I've omitted, ma'am, you could please remind me. Thank you.
Thank you very much, HOD. I know that Dr. Carter has some follow-up questions. Dr. Carter, do you want to come in now?
Thank you so much, Commissioner, Chairperson, as well as DG and Dr. Wagner. Just one or two follow-ups from my side. We've heard that incidence of severe acute malnutrition, it leads to stunting, and we've got a very high percentage of stunting or stunting rate within the Eastern Cape as well as South Africa. Do you accept that every rand that we basically not invest in the prevention of SAM cases, that it would be multiplied in the future in terms of health expenditure and the economic cost it would cost the department to address these in the long term? That's my first question. And then I'm still a little bit, if you can see the nexus between us trying to determine whether children who have birth certificates and then have access to social grants, such as the CSG, is there incidence of severe acute malnutrition deaths? That's what I'm trying to ascertain. Is it lower? And is there a way for us to make that data HOD Wagner, I know from day one I've met you, you're a data fan, you love data. And is there a way for us to get that information? Because that for me would be very clear. We are very clear as the Commission, and Commissioner Makwasha also champions human rights-based budgeting approach. We want to see that the fiscus is pushed towards, firstly, human rights-based budgeting. And if we do an analysis of the costs that it would come to the department in the long run of addressing stunting and the economic costs to the province and the country of not preventing these cases, and DG, you've identified it through a targeted approach by means of the child support grant, are we not failing our long-term strategy of economic development because we are just not investing in the right space? And why I'm asking these questions is we are going to have Treasury here tomorrow. We have been engaging with Treasury much like yourselves, and we are going to have to make this analysis, because it's simply not enough for the Commission to say, you know, there's no money. Ours is to ask, where is the money? And is it applied in a human rights-based, responsible manner? So for me, the data, are we connecting the child support grant access with birth certificates? The Department of Home Affairs is going to be here. And are we investing in preventative measures enough, in your view, vis-a-vis what we're going to face in terms of stunting in the future? That's it from my side. Thank you, Jeff.
Thank you, Dr. Carter. DG or HOT, do you want to come in on those?
Thank you very much, Commissioner. Dr. Carter will come in, but on the issue of birth certificates, that's one of the reasons why we partnered with Home Affairs to introduce birth registration within the maternity facilities, even though we've not reached 100%, is to ensure that at least a kid that gets born within a health facility must get out with a birth certificate. Because as you're probably aware, in terms of civil registration, South Africa is number 2 after Egypt. We're sitting at, in the last year, we're sitting at about 89%. Egypt is close to 100%, but there are countries they don't know themselves how many they are. But even that 89% of us, it means that we have about almost 6 million South Africans which are unregistered. That's one of the reasons we've been talking to the other people. Say, if you want to ask someone for an ID, you're going to exclude almost 6 million South Africans because they don't have IDs. So it's one of the areas, and we know that a birth certificate is your license to a grant. So which is why we work very close with Social Development and the Department of Home Affairs, not only by registering, but if we pick them up, how do we then get them in terms of late birth registration to be able to get that. But in terms of the data, I will ask Dr. Wagner, because in terms of the link, but I think it's a very important question because it strengthens our case for the child support grant if we can prove that there's a link with severe acute malnutrition with the access to the social grant. Now, in terms of the investing in the right things, now you are preaching to the converted to us. I'll make an example. We introduced the vaccine, on the pneumococcal vaccine, the PCV and the rotavirus for children because that was the cause of death and the admissions. But we needed to convince Treasury. But now they saw that the admissions for children under 5 went down, but you needed to make that decision and make that investment so that you actually see the value in the long term as we move forward. I mean, it's a similar issue. I've been with the HIV program since 2000, that we're seeing that when we're to argue that if you actually put ARVs, you're going to cut TB deaths, you're going to cut people who got MDR-TB, and you need almost 800,000 to treat them. So, but these are the decisions that you need to make as a public health official and convince your treasury, but you must make a proper business case. So even in this one, the data that the commissioner is asking about for us is very critical, that if we get that data, we have a better ammunition to go and argue with our social development colleagues through the social cluster to say, if we invest in this, these will be the outcomes. These are the lives we're going to save. This is what we're going to save from unnecessary hospitalizations. The mothers who have to look after these kids can have time to go to work. It's quite, and the lost days in education. So it's quite a lot in terms of the benefits of that. I'll allow my colleague to come in.
Thank you very much. I'll respond to the data issue first. So the short answer that when it comes to the individual child who was identified, it's the clinician who will inquire whether or not the child had a grant, had access to the grant. So I would have to go down to that individual record to be able to track and trace that. Unfortunately, as I'm sitting here, I can't access that. I would have to go and inquire, and that is the gap in the collection of data that will be useful. I wanted to talk to the issue about prevention. There's no argument against the fact that investment in prevention and health promotion will yield downstream activities. However, I want to just point out to the Commissioner that it's not as simple as that. I think the issue of healthcare financing is a very important discussion that we need to have as a country. Starting at the firstly, as South Africa and the Eastern Cape is no different, we're undergoing both a demographic transition and an epidemiological transition. So that means we have more people living longer, but we still have a large percentage of people who are young. So in the Eastern Cape, just under 34% of all people, 33% are under the age of 34. That means you have a high demand of communicable diseases services, maternal, women and child health diseases services. But we also have 11% of our population who are over the age of 65. So now non-communicable diseases becomes a challenge. So as we have this change in population, there's a change in the burden of disease, more trauma and injuries. So as a health system, with the money that is given to us, we have to find this balance of investing in prevention and promotion, but also dealing with the increased demand for maternal child health services. Our facilities in the Eastern Cape, we have the highest number of hospitals in the country, many of them 90 in total. Many of them were missionary hospitals. So these hospitals, when they were built, were designed for a smaller population. They were designed not for the current burden of disease. So with the money that is available, we have to change our service delivery platform to try and address both volumes of people as well as address the fact that it's a different type of service that you now need to adjust infrastructurally but also service-wise. And so you must also change the capacitation of your professionals. So it's quite complex in trying to deal with it. But we have an understanding, a deep understanding of what we're doing, and we're on that path. So there's a higher demand for services, and therefore your budget is now under pressure to deal with historic inequalities like the infrastructure challenges in the Eastern Cape. The Eastern Cape also, our communities are deeply rurally located, and that is why we've shifted towards the community ward-based outreach teams, trying to invest in community healthcare workers and pushing towards households in order to promote access to healthcare, because we know our communities can't always get access to our facilities. So that being said, if we were to ask Treasury, the National Treasury and Provincial Treasury, I'm sure DG will raise the fact that when you look at the percentage of GDP being spent on healthcare, thank you, are we optimally utilizing the budgets being made available to us? So yes, there's an increased demand for care, and there may possibly be a counter-argument that we're getting the right proportion, but are we using it? So in the Eastern Cape, I'll talk to the Eastern Cape, and DG I'm sure can comment in parallels in other provinces. One of the biggest impacts on our budgets and our ability to provide care has been the impact of the medico-legal claims against state. A lot of those were related to historic claims from many years ago that are coming through the courts, and there were lump sum settlements that had to be made in order to settle that. So we have accumulated debt, it's called accruals and payables, to the tune of 7.3 billion rand. That means that when we start a financial year in April, we first have to pay the debts of the prior year in order before we can then pay the current creditors. So it's a vicious debt cycle that you become trapped in that we're trying to deal with. So we have an integrated medico-legal strategy. That came out of our operational budgets, taking money away from care that should be provided. But through the integrated strategy year on year, we've spent about 330 to 370 million each year for the last 3 years to make medico-legal settlements because of the case and the way in which we're handling the medico-legal claims against state. So to seal that off and optimally utilize available budgets, the law reform that is being driven by the National Department of Health is important to provinces like ourselves, because the intention is to cap the amount of claims against state, the liability, but also to use mediation and other means of trying to redress that. We have to improve, and that's a very important part. We're dealing with unscrupulous lawyers. We have a forensic investigation and I think the Commissioner are aware of those instances where there are cases before the Commercial Claims Court. We've handed over 25 firms to the Legal Practice Council for 75 cases of suspected trust fund irregularities. And then on the clinical side, we've launched 4 regional clinical governance committees, and our clinicians are being organized according to domains so that they look at the data, they look at why children die, where they're dying, how are we working together to address this and improve the quality of care. So that's a significant part of what we're doing in the Eastern Cape now. The other, to come back to the healthcare financing, which is the heart of the question, so stop the losses. The second important part is optimization. As I said, our service delivery platform in the Eastern Cape, it outstrips the money available to provide care. So we are going through an optimization program. We've got a draft new service delivery model that is aligned to NHI. That model, there's a big consultation process internally, and our Honourable MEC will lead the consultation externally, but we're using a hub and spoke approach. In other words, instead of 65 district hospitals, some of which should not be classified as district hospitals, they will be repurposed, reclassified, and we will probably move towards a 28 to 30 district hospitals with community hospitals feeding into the hub, so that the available resources can capacitate district hospitals that can function and provide the full package of service. So that restructuring is a process that we're underway to optimally utilize the available budget. Then we are working with the World Bank, the National Treasury, Provincial Treasury, to look at how we can restructure our debt so that we can have cost savings on the one hand to refinance the debt and pay it across a 6 to 7 year period. So that is technical work that to be accelerating now. And then obviously digitization is a very important part. We, as the Eastern Cape, we've developed the electronic patient record system for hospitals. It's called HMS2. We've rolled it out to 41 of our hospitals, and phase 2, which is the clinical record for the individuals, is been rolled out to 8 of our regional, tertiary and central hospitals. Our national department has done an assessment to see if this is also a solution for the country to utilize, and the Free State has already rolled out our system to hospitals there. So we're moving in the direction of having an electronic record that gives us information about the patient so that we can have more targeted interventions and direct our resources to where the burden of disease is most required. And then finally, strategic partnerships assist us in boosting the budget, and we think we can collect more revenue, and those that we've got a number of different projects. I share this with the Commissioner to show that we are doing the best we can to try and optimally utilize the available budget. We do believe that if there was money made available, our community development workforce can be expanded. It's a very important cadre that allows us to cover all of our wards better and cover more of the population. So I think that would make a big difference if we could strengthen that. That being said, I think we also need to strengthen, again, an electronic record system that brings all of the partners together to link them automatically. It would be really useful, because there are strategic partnerships that we have lots of strategic partners whom we work with to try and strengthen community-based interventions. So that was just I wanted to just raise the issue that is likely to come up from Treasury is, firstly, let's utilize what we already have, and I would agree with the Commission that investment in prevention and promotion and strategic marketing would be useful. But looking at what drives behaviors, so the universities, anthropology departments working with us to understand what drives behaviors, and then having targeted national strategies, provincial strategies and local strategies to address that. We are already trying to do that through the endowers that we host locally, and then work with community structures to try and address issues like social problems like teenage pregnancies and the social determinants of health. Thank you very much. I think I've responded to the questions.
Just to add, she mentioned in the whole country the accruals are sitting at 25 billion. Now, why I'm raising this is because when we go to Treasury, they're saying you're bleeding so much. First, show us your efficiencies before we can give you money. Thank you very much, Commissioner.
Sorry, just to add, in that regard, because of the interventions in the last financial year, when I came back in as accounting officer, we had levelled off the debt. There was a spike that in the main was related to some of the cuts in the cost of employees. But then we've that trajectory, we've now decreased it by 499 million rand less that we would have spent had we not been put in these interventions. So we really are trying to control the expenditure. We're not perfect, but we are making efforts to try and control, and we've implemented austerity measures to try and control line item spending, just in support of what the DG has said. Thank you.
No, thank you so much, HOD, and thank you very much, DG, as well. I'm aware also that you have time limitations in terms of some planned travel. I am covered by the questions that have been asked. I do have just some comments here and there, and maybe a question or two. I'm alive, and clearly from your own responses, you are also alive that we are operating within an age or an era of multiple intersecting crises. So we have this crisis of child malnutrition, but it's operating and intersecting with all of these other crises, the financial and economic crisis, the teenage pregnancy crisis, the food insecurity crisis, and many other crises that make it very difficult for us to address one issue without addressing the other areas of crises as well. And this is perhaps where the emphasis on prevention comes in, and I'm pleased, HOD, that you were able to capture our interest in the preventative mechanisms that we can put in place. It seems that not just the Department of Health, but the country as a whole, because of the feeling of being overwhelmed by these multiple crises, we are operating in a reactive mode. The crisis happens and we must then employ our resources to react and less on prevention. In your presentations, you have, under the causes, made it very clear what in your assessment are the causes of the crisis that is under hand. And of course, mainly it's the food insecurity, it's poverty, it's unemployment, and those crises that are intersecting with this. South Africa is a country of contradictions. On the one hand, we have a crisis of food insecurity, a crisis of hunger. On the other hand, we waste around 10 million tons of food annually as a country. That's around 61 billion rands a year of food that is wasted. And this is operating along the crisis of hunger, where children are dying and families are going to bed at night without food. So this dichotomy and contradiction needs to be addressed, and the Department of Health has its own role to play. We were quite inspired to hear about this intersectoral collaboration group where you work with the Department of Home Affairs and Agriculture. I didn't hear much around what this group is doing on preventative mechanisms. If the problem is food, surely the conversation around preventing malnutrition also has, at least at the level of that intersectoral group, be around land rights, the availability of land, around the role of agriculture. You spoke about cultures, you spoke about promoting cultures of food gardens in communities as a mechanism or as a strategy to address some of these issues. So this is much a comment, but I'm also interested in finding out from yourselves to what extent is the conversation happening at the level of this intersectoral group that speaks about the issue of availability of land, changing cultures towards self-sustainability, and so that you can decrease the reliance on the state as well. You can decrease the urgency of the conversation around increasing the child support grant, at least to the extent that it is being held as a measure to address food insecurity and its effect on malnutrition. So that would be the first question that I would be interested to hear from you. Linked to that, Commissioner Makosha has asked you about the question of teenage mothers. We in the South African Human Rights Commission have been and continue to be concerned around the roles and the responsibilities of the Department of Health amongst many other departments in the discourse and the framing around the pregnancies of children. In many teenage pregnancy, which then takes away from the underlying problem that within this group there are those who are victims of statutory rape, which is a crime in terms of the Sexual Offences Act. I would be interested in knowing at which level or to what extent are we, when we are grappling with the question of malnutrition and preventing malnutrition, particularly as we look at its effect on teenagers. To what extent are we extending the conversation towards child pregnancies and the legal ramifications where children are concerned? And I mean to point to statutory rape and the responsibilities of the Department of Health in reporting these cases. I'm thinking here also, I wonder the extent to which then justice would come into the intersectoral group as an the numbers that you showed, Nelson Mandela having the highest numbers. One would expect, given the Eastern Cape being a largely rural province, and if we are problematizing this issue of nutrition as a poverty, as a food insecurity problem, one would assume that its prevalence is in the more rural regions of the Eastern Cape. In terms of your own assessment, what accounts for Nelson Mandela Bay being an urban region or metro having the highest numbers of children affected with malnutrition and, of course, the high number of deaths? And then the last question from my side, or the second to last, is the nutritional support programs that you are saying you have provided as one of your intervention strategies. Are you able to just clarify to us what those entail when you speak about nutritional support, what that entails? And then the last one speaks to Turbifos. DG, I was very pleased to hear you mention Turbifos. The South African Human Rights Commission has been in the forefront of advocating for the banning of Turbifos, but also the eventual banning of all highly hazardous pesticides. We congratulate the Interministerial Committee for the banning of Turbifos, but we remain highly concerned in our engagements, particularly with farm workers, with farm dwellers, but also those who are victims in the townships in particular. They are not aware that Turbifos has been banned. The question on our side is, to what extent is the Department of Health supplementing the banning of Tebifos with a public education campaign that makes the public aware that firstly the deaths of children in Naledi and Soweto is not caused by spaza shops and expired foods. It is, as you have correctly pointed out, DG, caused by contamination of those foods with Tebifos, which now is a banned organophosphate. So to the extent that communities may not be aware that Tebifos is one, the cause of the deaths, but two, that this organophosphate has been banned. Now, of course, linking this to malnutrition as one of the causal factors, to what extent are we then marrying this recent ban to a public education campaign, particularly in taxi ranks, in the farm worker communities, where people are buying and accessing Tebifos in unlabeled formats? Thank you so much.
Thank you very much, Commissioner. Let me start with the Tebifos, just to frame the cabinet decision. When the decision was made, because this is really under the purview of the Department of Agriculture. They were then instructed to then take over the process, but so they are actually leading because it's under their own statutes. But also one of the big issues with this Tebifos is that it's actually illicit. It doesn't come through the normal processes because it is one of the highly hazardous. There's supposed to be a register when people buy it. It looks like it's coming through some illicit means, which is becoming a big issue. But what is the underlying issue? Again, it's an intersectoral matter, because what was discovered when we did all the work with the environmental practitioners is that the issue of waste collection in the township and the proliferation of the rodents, which are no longer responsive to the normal anti-rodents that you use. People then they started to use this because it's highly effective in doing away with the rats. So the bigger problem was, how do we get our townships cleaned and the dirt removed so that we don't get rodents? I mean, we all know about the Alexander rats. It's been in the newspapers. So these are the issues, but the department that was tasked to lead, because it's within their status, is the Department of Agriculture, which is supposed to report regularly to Parliament in terms of how, because this is legislated in their own way, so they need to put in some legislative measures to take this decision forward. And then in terms of teenage pregnancy at a high level, before I give to my colleague, what we've done through the social cluster, which DSD is part of that, the Department of Women, Department of Women, Youth, the people with disabilities, yes. I always use the acronym. Well, we've put together a task team that we've asked them to lead. And that task team has got Department of Health, it's got the Department of the Social Development, it's got a Department of Basic Education, because we all have the role to play, but they play a coordinating role in leading this, so that we all work together to try and see how do we address these issues as we move forward. Actually, we had a social cluster ministers meeting on Tuesday evening, where they are supposed to report back, but unfortunately they did not have time, so we're meeting in the next 2 weeks just to bring everyone together, because health alone is not going to be able to do this. But there's another department also that is very important, which is the department that, how do we also ensure that the young children are not lured easily using finances? How do we expose them to some economic opportunities and all those areas? So it's quite a lot of work. It's a long way to go. We come in mainly on the biomedical, but answering a specific question of what do we do when we get a 14-year-old, because there's statutory rape. What we do, we put a protocol with Department of Social Development, because normally when they come to us, they are in need of help. So our priority is to provide the health services. And then there is a form, I've forgotten the name of the form, that because they have to refer the case to social development, who then have to deal with the matter and then take in terms of how does that case get reported. I know it's been a huge social arguments whether nurses should actually be reporting this to the police. We'll end up, we're looking at the clinics. Clinic is only run by 2 nurses, and in some instances there's probably 1 nurse. Imagine if this nurse moves on to now go to the police station. Once we've opened up a case, it's an argument that we're still discussing. We're not saying we're taking away the responsibility. Then the nurses will end up sitting in courts every day for these cases. So this task team led by the Department of Women is one of the issues that we're saying responsibility must be clear. Is the current system where we refer to social development not working? If it's not working, then what is a better system that we can use whilst we ensure that we also do not remove nurses within their work environment in terms of providing the services? So we don't have the answers as yet. So there is that system, but maybe my colleague from social development later will talk about it because it exists, the referral to social services. In the institutions where we have what we call the Tutuzela care centers, it's very easy because then the Tutuzela care centers already has SAPS, it's got NP, actually it's run by NPA, but it's housed by us. It's not enough. We only have 65 in the country, and looking at 65 when we have 389 hospitals, it's really a drop in the ocean because there the matter just gets referred there is multi-sectoral. If it was for us, it would work because our social workers is already an integrated pattern. Maybe if we can invest in that. But do we need to invest in that, or do we need to fight gender-based violence so that we don't need to be spending so many resources? That would be what I would say. But we'll be able to report once this committee that is led by the Department of Women assists us to say, if this system is not working, what's the best system to do? Thank you very much. I'll ask my colleague to come in.
Thank you very much, DG, and thank you for the questions. I think the DG's addressed the question that you raised, Commissioner, holistically, and everything he described as what is being implemented in our province. We do have a JCPS cluster, which is your Justice Crime Prevention cluster, and we are a member of that cluster. It falls under the Social Protection and Community and Health Development cluster, which is led by our MEC. We're currently going through a review and preparing for our strategy for the next year, and taking our cue from the Commission, the teenage pregnancy, because our MEC is passionate and wants to lead that in the province, will be incorporated into the cluster as a specific emphasis of matter over and above the other justice and crime prevention strategies that we are driving and working together. Just to answer the remaining questions on Nelson Mandela Bay. So we actually have a coordinated intervention in Nelson Mandela Bay, and it arose out of what you would probably have observed at Doringinza Hospital with mothers that were on the chairs, etc. And that crisis arose out of a number of converging factors. So starting point is, as I described about the increase in population and the changing demographics and the changing in the burden of disease, Nelson Mandela Bay, because it's one of the 2 metros, attracts a lot of people. So there's been an increase in the population and an increase in the number of informal dwellings in and around. And so our health system needs to be adjusted very sharply, and that is why we now have this integrated intervention in Nelson Mandela Bay. It's led by, because the Bay and Doringinza in particular, the maternal and child health services are provided at Doringinza Hospital. But to be able to deal with Doringinza's quality of care issues, we have to take care of both primary health care as well as the tertiary services. And so I can share the report that we've just tabled to the Public Protector on what it is that we are doing to address the service structures for mothers, starting point mothers, as well as the children within the Nelson Mandela Bay area. It incorporates Sahrc as well as Nelson Mandela Bay. Our big challenge, so it's increase in population, increase in informal dwellings, placing a strain on the health system. We, as part of trying to address that in the context of what you were asking, we have, there isn't a district hospital in the Nelson Mandela Bay area, so we are repurposing one of the TB hospitals to become a district hospital. And we started first with creating a 30-bedded ward, so the infrastructure, the contract has been awarded, and we will start renovating one of the existing wards so that women women, once they've delivered, can be moved postnatally to the Empolweni, freeing up beds inside Doringenza. We've also brought on an additional board at Doringenza, 30 beds as well. We've completed the infrastructure. We've procured all of the equipment for the wards. We started staffing as well. So the ward C13 is now ready for that means that once you've delivered the mom, you have more beds to move her out of the... Then the reason that crisis also happened was related to staffing. We did not have enough anaesthetists. It decreased the number of slates. Doringenza receives predominantly high-risk women. So that means you need more people requiring caesarean sections. And so if you have limited theatre space, it decreases that. That was called, we found beds for all the women by between 1 and 2 obstetrics and gynecologists. And that was just so that we can start bringing in staff and doing caesarean sections. We also are activating and expanding maternal, women and child health services at UPH, and so that they also have additional beds. That's 15, if memory serves me correctly, at UPH. We also asked them to start doing caesarean sections. The other challenge we had is that Sahrc does not have a regional hospital. They had a problem with their theatres in that they didn't have theatre-trained nurses. So with them not operating and doing caesarean sections, those patients were now coming to Dora as well. So it was an influx from Sahrc. So our intervention is building capacity in Sahrc. We're using agency nurses now while we're permanently recruiting for the theatre at Humansdorp. Humansdorp, we're taking over the ward when the public-private partnership comes to an end now, so that we can increase the capacity in Sahrc and provide services closer for mothers and children in that area. So that is part of the interventions. And then within Nelson Mandela Bay itself, your community health centres need to be functional 24/7, and in that instance we are doing it's PE Central as well as Motherwell, KwaZulu-Natal. We have infrastructure projects awarded to providers to expand our capacity and decrease the burden that's going through to Doringenza. So we really are making an effort to restructure the health system to better adapt. At Dora, the tertiary services are moving to Livingston, and then that's for both pediatrics, children, as well as mothers, and then of course the regional services moving from Livingston to Dora. So we really are reconfiguring the health system to better meet the demand in that area. It does require significant investment in infrastructure. We've done an application to the Presidential Fund, and this is again is where the Commission does assist us when you lobby for us, because that application, if awarded, will allow us to unlock available infrastructure, repurpose it to better meet the demands of people in that area. The one challenge I must raise in Nelson Mandela Bay is safety. We do work with community-based organizations with SAP and crime prevention, but it really is a burden to us as a department when our staff just yesterday, there was a vehicle that was hijacked as they were delivering the CCMDD, the chronic medication. And then we have to, it affects our clinics because we have to close that clinic. When we were there on Tuesday, 2 out of our 39 clinics in Nelson Mandela Bay was closed because of crime-related issues. So those social factors do impact our ability to keep clinics open and to provide services continuously, even at our community health centres in Motherwell. That being said, our MEC has had a meeting with MEC Ngata from Safety, and the two departments have put together a task team that is focusing on the crime issues affecting our clinics in hotspots, our EMS services, because they also in the past have been robbed, hijacked, as well as dealing with issues of the bodies in our forensic pathology. So we are trying to work with other departments in a more coordinated way, and we're hoping to see that impacting positively on the services that we provide. So that was Nelson Mandela Bay and why the numbers. And then with respect to nutritional support, I have in the room with me my two managers who are nutritional experts, and I think they would balk if I had to dare pretend I'm an expert in their field. I'm not. So what we can do is, besides knowing that we've allocated 21 million rand towards nutritional supplements, so I did explain earlier that when we go out into the community, we find when we do the mean upper arm circumference that a child is at risk, we connect them to the clinic so that they can access these nutritional supplements that are given to them. And then the other supplements that we have within our hospitals, there are certain clinical protocols to be able to provide supplementation. Last year, the national contract assisted us because we did highlight we had some procurement delays in procuring. We never had stockouts, but there were delays. And so we were doing quotations every time we needed supplementation. Now, because we have a national contract in place, those supplements are easier to procure. And then the other component where there were gaps in the national tender, we did an extension and went out on contract. So we have a 36-month contract. We've allocated 5 million rand across this 36 months, and that is to deal with the various consumables to be able to give those supplements to the children. So it's called when you've got to inject it in, directly into the veins so that they get supplementation. We've now put that in place, and we've allocated budgets towards that. So it's providing supplementation for the mother and child. There are other departments and community-based organizations that also provide supplementation to households at that level. And then, as I say, when they come to our facilities with a diagnosis of severe acute malnutrition, we then have appropriate supplementation to resuscitate the child. Then we put them back into the community where they are supposed to be followed up. They are followed up by our ward-based community outreach teams, continuously monitoring the child's upper arm circumference until they reach the stage where they are no longer malnourished. So those are some of the nutritional interventions. I think the DG answered your final question. Thank you so much.
Thank you very much, HOD. Dr. Carter, any further questions? Commissioner?
Just one last one. I just want the comment on the statement. Malnutrition further poses an immediate and long-term threat to children's health, survival, and development. It weakens children's immune system, contributes to under 5 mortality, hinders physical growth and development, impedes educational and employment prospects, and perpetuates a cycle of poverty and ill health across generations. This slow violence of malnutrition is often overlooked. And
thank you very much. Thank you. I'll then hand over to Dr. Carter to just guide us in terms of the program.
Thank you so much, Chairperson, Commissioner. We will be hearing from the Department of Development next, and we do call them to the front to come and take their seats. The proceedings will then similarly be under oath. And just a kind reminder again to all participants, we are live streaming, and you are welcome to also indicate whether you need a body break. We are 20 minutes a little bit behind schedule, but we do feel that it is very important for us to deep dive into the next session immediately. And maybe we can, maybe we can just delay our lunch break a little bit by perhaps a half an hour. We can just arrange, and then we can hear from the Department of Social Development. Thank you so much. report follow-up on the recommendations that was issued to various stakeholders in 2023. We have heard this morning from the Department of Health, not only national but provincial as well. And for those who have just joined us, the department has shared statistics with the Human Rights Commission under oath, and it has shown that in the 2024 financial, or in the calendar year of 2024, 573 children have died as a result of severe acute malnutrition in South Africa. And specifically for the purposes of today, in 2024, 107 children have died as a result of severe acute malnutrition, which was the subject matter of the Human Rights Commission's inquiry into matters of health and the rights of children 3 years ago. Now, I'm going to hand over to Commissioner Ntuli, the chairperson of this panel. She's joined by Commissioner Sahrc Malnutrition, and we will be hearing from the Department of Social Development. I do request the department that where they have delegated to the authority to also expressly indicate so. Otherwise, the Commissioner will be administering the oath. Commissioner Ntuli, I'm going to hand over to you, and then Commissioner Makwasha for the oath. All right, thank you.
Thank you very much, Dr. Carter. Good morning, colleagues, and welcome. Good morning. Thank you so much for attending today's subpoena hearing. As Dr. Carter has indicated, I am Commissioner Ntuli, and I'll be chairing the session this morning. Before we proceed, I will then hand over to Commissioner Makwasha on my left to administer the oath before we proceed. Thank you so much. Over to you, Commissioner.
Thank you so much, Commissioner Ntuli. I just want to confirm whether or not the relevant stakeholder is before us, who has been subpoenaed, or alternatively, is there a letter confirming that he has appointed someone on his behalf?
I'm the DG of the Department of Social Development. My name is Peter Nechipare, the DG of the National Department. And then I'm with the Mr. Brandon van Vierde from the Grant Administration in SASA, our entity. And we have got Mr. Tola Nchona, who is he has been delegated by the HOD. He's not the HOD. He's the chief responsible for community development. And on the far end, we have got Matretuka. Matretuka is the regional executive manager of SASA. So that when you say Chris Hani, he must know exactly what happened in Chris Hani. He is at the national level looking at the policy. I am at the national level looking at the all 9 provinces, including Eastern Cape on this matter. Thank you.
All right, just the representative who has been delegated by the HOD, is there a formal letter providing you with that authority?
Yes, Commissioner. I understand the copy of the letter was forwarded to National Manager, Dr. Carter.
Dr. Carter, do we have receipt of that letter? Thank you so much. So based on the presentation, are you all going to be taking the oath because you're going to be providing specific information, or one particular individual?
I think we must all take oath because I'm going to paint a picture at a national level. But the emphasis of the matter with a specific area, I will hand over to each one. For example, what do you do to make sure that more children in Chris Hani are given grants? He will respond. What are you going to do to make sure that the regulations is whatever? He will. How many NGOs or MPOs and CBOs are giving food in the areas that you're looking at? I will. But the main presentation will be made by myself. In between, I will ask the specific person to elaborate more clearly.
So we'll start with you, sir. Just stand up as you're going to take either the oath or the affirmation. Are you taking an oath or an affirmation?
Oath.
Just for the record, your full names.
Fumulani Peter Nechipare.
Do you swear that the evidence you're about to give shall be the truth, the whole truth, and nothing but the truth? If so, raise your right hand and say, "So help me God."
So help me God.
Thank you. The next gentleman.
Thanks.
Your name for the record.
That's Brenton van Vrede.
You're going to be taking an oath or an affirmation.
No, this.
Do you see that the evidence you're about to give shall be the truth, the whole truth, and nothing but the truth? If so, raise your right hand and say, "So help me God."
So help me God.
Okay, can we pass on? Full names for the record.
Wayne Gola Njona,
Are you going to be taking an affirmation or an oath?
an oath.
Do you see that the evidence you're about to give shall be the truth, nothing, the whole truth, and nothing but the truth? If so, please raise your right hand and say, "So help me God." We cannot hear.
So help me God.
Thank you. The last gentleman.
Let me stand here. Okay.
Full names for the record.
I'm Bandile Maqethuka,
Will you be taking an oath or an affirmation?
an oath commissioner.
Do you swear that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? If so, raise your right hand and say, "So help me God."
So help me God.
All parties have been duly sworn in. Back to you, Chair.
Thank you, Commissioner Makwasha, and thank you once again, DG and your colleagues. As indicated, you are here because notices have been submitted or sent to your offices. We have requested that you make submissions to the Commission in line with the items in those subpoena notices, with specific reference to the outcomes or the recommendations of the Commission's 2022 inquiry into child malnutrition. DG, we will now hand over to you to walk us through your responses, and thereafter we shall engage with you. We have received a PowerPoint presentation, and I'm not sure if it's going to be flighted.
Yeah, there is flighted.
Thank you very much. Over to you, DG.
Thank you very much, Commissioner. And really, we are going to give you a presentation that details what the department have done in line with the recommendation, and up to a certain level. Some of the information is not all in the presentation. There's a Word document that we have submitted. There's also evidence in terms of when we said we have got eye crop, what does it mean, what we're doing, which I think it has been sent or it will be sent. This presentation is just to outline the broader perspective in terms of the response that the Department of Social Development has prepared. It will have purpose, some background and the context, a response to the Human Rights Commission report, the role of national and the role of the provinces, and some detailed data on the child support grant and the national role and support that we provide since the report was published. I think, so the purpose of this, can you go to the third slide as I speak? The report, the purpose is to present this report on our sector presentation to you today on child malnutrition and the right to food in the Eastern Cape province. The DSD mandate is broad, and it's got a broad responsibility, but above all is in line with the alleviation of poverty and the provision of access to food in terms of the Constitution. The department received this initial report dated August 2022 on the child malnutrition and the right to food that was conducted by the Human Rights Commission in the Eastern Cape. The Commission initially outlined specific targeted recommendation specifically for the department, which relates to the department, the organizations, and other government bodies to address the malnutrition crisis comprehensively. Specifically, the Commission recommendations were that we must increase the child support grant to be above the food poverty line, that was the recommendation. Prioritize children under a school-going age for child support grant increase. In other words, look at those that are not going to school, because once they go to school, they get school nutrition program. But those that are not going, we need to target those, and also partner with other government departments, like the Department of Home Affairs, for the registration campaign that target these children. We received the notice, and when we received the notice, already we were hard at work to ensure that we deal with the issues that was recommended, which was a clear indication that for us to serve this country and to look at the poor of the poorest, one of the things is to look into that. It was not even something that is not doable. It needed us to begin to do the work. The presentation that I'm going to make here, I don't know who's, I will just raise the hand. You must go to the next one. Yeah, it outlined issues that have been requested. There were several issues that you outlined a lot of issues, which are about 8 or 9 issues that we need to deal with individually, which is very specific. The first one, next slide, the next one is to look at the national role. I think let me start there to say what is the national role in ensuring that what we were mandated to do is done, and kids or children in the Eastern Cape are taken care of. So the department has a tracking of the implementation of food and nutrition security interventions that has been planned by province, which this included the administering the social security provision to cushion the vulnerable families and affected children. And we have developed the provincial food and nutrition security plan. One of the issues that we identified as national, in 2018, we developed, and I think Health also mentioned it, Household Food and Nutrition Plan, which is a country's plan that says how department need to ensure that everyone is catered for: children, young, youth, women, older persons, because we get a lot. And I think Health should have told you that before the report came out, there has been a resurgence of certain diseases that are not supposed to be. Kwashiorkor, marasmus. You don't need to have malaria in this country. This country is food secure. So once you see those things coming, then we say to agriculture, let's develop a comprehensive food and nutrition plan. So that plan, Eastern Cape didn't have that plan. When everyone did, Eastern Cape did not have a plan, because they need to account to the Premier, which account to national, where we need to say, what are you doing about that? So one of the things that we did as national is to come back immediately and say, you will have a plan developed that detail how each and every department will focus on the well-being of children that are reported. Lucky is that these malnutrition are captured from the point of the Department of Health. You know, the data that he showed you, severe malnutrition, people that are admitted. Immediately you get that, it must be reported to everyone, so that we must intervene, including social development, agriculture, and others. I think we have ours here, when you mentioned the referral pathways is the ones that are not. You will pick it after 3 months. But what have you done immediately? You pick up that severe malnutrition under 5 is a priority in the country. It's like maternal mortalities for under 5. It's one of the key. It's an indicator for the country that you don't need to have those. Once you have it, you need to run. We also have appropriate coordination structure. We ensured that those structures need to function optimally, wherein all government departments meet coordinated by the Premier to make sure that there is a plan. So we also did what you call the capacity building, but that was focusing on the DSD only in terms of what they do. We have got certain areas that we look at. So we were responsible to make sure that we need to do that. We also need to have a nutrition plan developed, and we need to have regular meetings that we need to have in the province, in the province, to make sure that everybody comes on board. Several visits to the province by national were done, especially with the provincial leadership, on the issues of food and nutrition security coordination matter, that must be coordinated, and it included all government departments. We then activated the support to the province on the development of that plan that I've mentioned, and to ensure that those structures must report back, so that periodically we are able to come back and report to you about the strategies that we need to. In the strategy, DSD, or social development's role, is on strategic objective number 2, which is to provide food and to provide social protection measure, which is mostly to protect vulnerable groups by providing, 1, social grants, by ensuring that the kids are referred, by ensuring that the drop-in center are working, by ensuring that it also includes other age groups, lunch-on clubs, etc. and etc. Now, one of the things that we did is to make sure that the Eastern Cape structure is established, as I mentioned. The last thing was to ensure that at a site where we provide food, you will realize that in the department we have got centers where food are provided, which is Community and Nutrition Development Center. It's not for kids, but it's for 19 to 59 that don't have food. But kids sneaks in several times from school because we provide nutritious food. We have got drop-in centers where kids from school need to go to that drop-in center, and they provide them with homework. There will be food provided. We also have child and youth care centers that we have, and we also have the home community-based care, where you go to if you go to the families, you will be able to make sure that the family has got something to eat. The drop-in, the issue of the other issues which much more preventative is the lunch-on clubs for Magogos. We said Magogos, that what they need to do is that they must gather somewhere, be active, exercise a little bit, and there we also provide food. So those are the entrance in terms of food provision, which caters for everyone that we have. You also requested us to provide the data that we are dealing with. I'm going to show you the data on the child support grant, which we are focused on children. As of August 2025, the total number of beneficiaries receiving the child support grant in Eastern Cape were over 1.8 million. Is it billion? Million. To the value of 1 billion. I'm interested in the money. This 1 billion. So we spend every month here. In the next slide, we spend over 1 billion every month providing child support grant. And I think when details are required, he will be able to respond. Since the introduction of the child support grant top-up, there is a top-up that I think I will ask Brenton to take us through on that. I think from here going forth. Over to you.
Okay. So the child support grant top-up is an additional 50% which a person can receive over and above the value of the child support grant. So in 2022, legislation was amended to allow the Minister of Social Development to offer differentiated values for the grant. There were two aspects, two policy issues that she was trying to deal with at the time. The one was around the challenges with the foster care system. So the top-up was primarily, initially it was implemented for orphans living with family, so it could be a grandmother, aunt, or so. And that was to be able to then allow them to be able to access a higher value grant, not quite the same value as the foster care grant, but more than the CSG, without going through the foster care process, which was a lengthy process requiring court processes, etc. And so many children were not actually getting onto the foster care grant. This then enabled more children to be able to take this grant up because it follows the CSG application process, which is much more simplified. The other key aspect that legislative change brought in was that it now enables DSD to also consider other areas where top-ups could be provided. So if you say, for example, in one of the Commission's questions is provide a CSG to the value of the means food poverty line, that itself would cost about 37 billion rands, which in the current, I don't think it would be that, and I suppose you have to speak to the finance people, but that would be very difficult to do. Although we did do a SRD grant, which is roughly 37, but even that government is still struggling with, because it's year on year. Every year they have to find the money just to keep that grant going. But what this particular legislation did, as you identified, for example, that first group of people who were orphans, because it was also having the policy around the foster care that we were struggling or wanting to address, we could then give this extra top up to a group of children who were then identified as being vulnerable. And that then, it doesn't mean you have to do it for every single child, and that makes it a little bit more affordable, and you can then progressively implement policy changes over time. So that provision is there in legislation, and the department is currently working on a policy review to see, what other areas can be that legislation be utilized for. And I suppose inputs from once that policy is out there, we'll also then take inputs from society as well. Then
next slide.
Next slide. So this slide is often, this is the CSG top-up, just for the Eastern Cape. Just shows how the grant has been taken up since April 2024. Fifth Way was about 16,000, just under 16,000 people that were on it since then, and it's now about 18 months later. There's 21,400 children that's receiving that grant. The next few slides looks at just general grant distribution through the country. So you can do the next slide. We'll just do it per district. That might be more interesting. So just in terms of the child support grant, there's 307,000 recipients of the child support grant in Alfred and Zol. The child support grant being the largest group of children. Then we obviously do have the care dependency grant and the foster care grant as well. Amatole is about 437,000. Next slide, please. Krasani is 230,000, and then Joe Kwabi is about 111,000. Nelson Mandela is 230,000, and Ortambo is 500. That's the largest amount of child support grant recipients at 521,000. Next slide, please. And Sarah Bartman, 114,000. Then in terms of policy work, I think I already mentioned the one around the policy, and just there's currently work being done by the department, sort of an overall review of the children's grants, not just the child support grant, but all the children's grants, which will look at both the value of the grant, the qualifying conditions, the means test. Sorry, teacher, I actually wanted to go back because this previous slide. So if you can go to the stats on.
Go back 3-4 slides.
The stats on the child support grant, the trend, because that will probably be.
Go forward. The CSG top up. Next.
Apologies.
Next.
Yeah, just the table
Next
after
one.
this one. So I wanted to speak to this trend because this might be, I'm sure the Commission is worried about that trend on the child support grant numbers going down. Now this is a big policy debate that government has had. Well, let me say, it sounds like government might not be, but if one so for example, the Treasury and us will have this discussion. It's around how should the child support grant be targeted? Should it be currently the way it's targeted? It's targeted at a very broad group of children. The means test is pretty high. It's 5,600 rands a month, which is above minimum wage if one just looks at the threshold compared to minimum wage. Or should you have a narrower targeting and a higher value of the grant? And that's based on the assumption that the money is a little bit tight. You're not going to be able to do a massive injection to, for example, bring everyone up to the value, the grant for everyone up to the value of the food poverty line. Then the question becomes, do you do more specific targeting at the most vulnerable children, or the sort of more higher level so if you look at, we include children from very poor households, those who have no income, but all the way up to those whose caregivers are working and may be employed even above minimum wage. And so those are key policy kind of considerations that we need to give. Now what's happening here is Treasury has also asked us to make sure that our targeting at the current levels are more accurate. So we have began to conduct a bunch of reviews across all grants, not just CSG, but so old age, all the grants. And we have found that there are a number of people that are actually applying for grants that should not be applying for grants. So we use various data checks, like checking bank accounts, getting data directly from the banks, checking credit bureau data in terms of people who, so for example, someone might come to SASSA and apply for a grant, say I have no income, I don't have a bank account, sign an affidavit and apply for a grant, but then they might go and take a loan out by a clothing store or somewhere else, and then obviously to do that you have to supply payslips, so that data gets recorded on the credit bureau. So we're now checking that as well to sort of see who's been trying to gain the system a little bit. The numbers, it's not a lot. It's not a lot of people that's been doing that, but you'll see then that small downward trend over the last couple of months, and also public servants. We've been doing mainly, in these years, the months presented, there's mainly public servants as well, people that we then look at different government departments where they may have not had a job when they applied for the grant, but then they got a job and they didn't inform us, and we picked them up. So that's why we are seeing a downward trend over the last while on the social grants. And that is a way then as well, saving the fiscus a little bit more money, and the discussions DG has to have with the Treasury is to say, well, with these savings, can we look at increasing the value of the grant? It's not going to be much because the savings is not that much, but you could add a few, maybe 10, 20 rands with this savings. But then there's obviously bigger amounts of money that will be needed if you want to do a much more substantial increase to the grants. Sorry for taking us back. We can go to the next slide.
That's good.
Okay.
Yes, go to the one, the draft policy.
So that's the big policy considerations that DSD is looking at, but there are also other things. And as I was listening to health, these are something you've also asked them. It's about how do you integrate with other government departments, making sure that people don't just have access to grants, but have access to a whole range of government services. And so that is policy work the department is also doing. You're jumping the slide, DG. It's also policy work the department is doing with other government departments to see how we can provide a more integrated service. I spoke about the one on the increasing the value, and then so one of the questions was about working with Home Affairs and making sure that, you know, caregivers or children without IDs can access grants. There's currently a provision in our legislation that does enable you to apply for a social grant without an ID document. And when you come forward, you basically just sign an affidavit saying, I don't have an ID document, and the circumstances around that. We will then issue you with we call it a Quad 7, but it's just a temporary number that we can identify you with. And then we would refer you to Home Affairs and ask you to come back within 3 months with proof that you've gone to Home Affairs and applied for an ID. Contrary to belief is that we suspend the grant if you don't get the ID. We suspend the grant only if you don't provide us with proof that you've applied. So Home Affairs might not be able to give you an ID in 3 months because they have a process they need to follow to make sure the reasons why you were a late applicant and so forth. Those are their processes, but you just need to provide us with some evidence that you did attempt to make that application, and then the grant will stay in payment. We might put you on review regularly so that we can try and keep track of progress on that as well.
Next slide.
That's pretty, I think I spoke through all of that. Sorry, this is a duplicate slide. So that's the ID documents. Not yet in place, but we're also having discussions with Home Affairs at the moment as well in terms of how we can more proactively share that data with them around the people who apply for grants without IDs. We've done some data analysis and cross-checks between ourselves and them, and now we're looking at how we can formalize that a little bit. So we've got an MOU in place with Home Affairs, but we're still at the point of seeing how we can operationalize that and have a better data sharing arrangement so that we can, so before the beneficiary so by the time the beneficiary comes to them, they would already know this person would be coming to them because we would have provided them with that information. Next slide. And then just in terms of awareness,
I think let's give to Matseduka.
One
of the questions that is there is that what measures did the department and Sahrc do to ensure that we improve access to child support grant? And I think this emanated from, I'll give it to Matseduka, emanated from...
DG, may I kindly ask you to speak to the mic? Yes, please.
Yeah. This relates to that a number of children or diseased children were not in receipt of grants. So the question was, why do we miss them and why are they not accessing it? He just indicated one area, which is any child born must go, even if they don't have ID or they don't have papers. They will be given opportunities within the next 3 months to do. So the next question that we have, which is 5.2.3, says that what did we do as a department to ensure that we improve access to child support grant, so that it's what you call no-miss approach. So I will ask Matsaituka to tell me what he's doing in all these districts. You started with awareness, iCrop, and others. Over to you, Matsaituka.
Thank you, DG. Good morning, Commissioners. DG, before I respond to that question, I would like to add some information to enrich this engagement with the Human Rights Commission with regard to the assistance that government is providing to children in our province. DG, the Executive Manager, Mr. Frank Frebe, has mentioned that in the Eastern Cape, we pay 2,887,172 rands on a monthly basis, 2.8 million. Out of that 2.8 million, 1,987,735 is grants that are meant for children in respect of 3 categories of social assistance benefits. Child support grant alone, we pay 1,913 children every month at a rand value of 1,077,379,520. 1,077,379,520. We also pay 25,107 grants to care dependence children with special needs at a rand value of 57,997 rands 170 on a monthly basis. In respect of foster care children, those who do not have parents, they have been taken care of by other people. The number is 49,622 children. On a monthly basis, commissioners, we pay 62,027,500 rands. If you look at the total population for Eastern Cape monthly, the economic investment that is made for social assistance in the Eastern Cape alone on a monthly basis by our government is 3.1 billion on a monthly basis. Coming to the question that DG has asked me to respond to. DG, here in the Eastern Cape, we have 61 service offices which are spread throughout the province of Eastern Cape. Over and above, DG, we have 264 counter services. It's mobile services, teams that move from their service offices to various communities where SASSA does not have a permanent office. On a daily basis, there are mobile teams moving from local offices to rural areas where we don't have a footprint. It's about 264 of those counter services that are attached to the 61 local offices. Furthermore, we have 19 banks that are assisting us with the disbursement of child support grant and any other grant that is payable in the Eastern Cape. But in respect of the question we have asked DG, we have what is called integrated community registration outreach programs, where SASSA will invite Home Affairs, Department of Health, and any other stakeholder of interest in terms of our mandate. We go to rural areas, commissioners. We bring a multiplicity of government services into one place. You find Home Affairs, you find SASSA, you find Department of Education, all government departments we invite to one area where we serve that particular community with other communities around that particular area. We target these areas based on research that we conduct. We also get inquiries and requests from various communities, and then we arrange an outreach program. Even next week we'll be at Mtata working with various government departments. We also have a partnership with the Department of Health. We have mobile offices that go to various hospitals together with Home Affairs, so that when children are born, their mothers are provided with the necessary documentation, IDs, birth certificates on site, and SASSA starts registering those children. we have a special project that is targeting children under the age of 2. It's a special project, fully funded, where we target those children. We're also working with schools, because our aim, commissioners, is to ensure that the children we provide with social assistance are attending school, because government, by providing this assistance, is investing for the future of our country and our children. Therefore, they must be linked to schooling, but it's not a condition for them to qualify to get a social grant, but it's an added work that we do working with other government departments to ensure that these children, they get into educational programs, that in future they don't depend on social assistance, they can be independent and be able to look after themselves. We are also working with community radio stations and NGOs in our region in terms of raising awareness and promote uptake of services targeting mainly children. At hospitals, we host sites for restoration programs, but we also align services with antenatal and immunization programs, which are rendered by the Department of Health. The aim is to enhance access to our services. We work with various stakeholders, traditional leaders, we work with them, work with community-based organizations to make sure that we get to all areas where services are not being accessed in our region. Let me stop there for now, DG. Thank you.
Thank you very much. I think that answers the issue where the issue of malnutrition. I think the motto is, it must never happen. No misapproach. Let's target them everywhere where you find them, especially with social grants, so that together we will be able to get everyone and deal with them. The other issues that I think on top of the issue of awareness and child support grant top-up is the issue of community engagement and community, we call them community capacity enhancement. You have to teach the mothers the parenting programs that the Department of Social Development does to the young mothers, how to take care of their children. This is done by social workers throughout. Also the department also conduct several sessions in different areas, which I will give to him in terms of other questions that we have. We also make sure that because we have seen that the value of social child support grant is smaller, there's other issues that we do to ensure that we add to the families. One of those is ensuring that children, they are given school uniforms. Then if you look at the Eastern Cape, over 24,000 school children were provided with school uniforms at the beginning of each year, to make sure that this is the vulnerable children that are born, I think including teenage mothers that are giving birth to these children. But from the national point of view, maybe I should give to them, because there are questions that relates to, which is 2.2, the total number of food parcels, detailed breakdown, and also the list, whether the list of NPOs and NGOs, I think Chief Director Nchona, you can come on those questions. Total number of food parcels that are distributed is in the report, the word report in terms of that, and the number of NPOs that provide those, and also distribution per province, where are they distributed. Over to you, Mr. Nchona, on behalf of the DG of HOD of the Department of Social Development in Eastern Cape.
No, thank you, DG, and good afternoon, commissioners. In terms of the correspondence that we've received, there are about 5 areas that we should cover. The first one is us providing an update of what it is that the department has done since the issuing of the last report and the recommendations of the commission. Commissioners, a lot of work has been done by the department, working with various other government departments and also extending our influence to cover civil society organizations, and also moving further down to ensuring that communities themselves are actually mobilized to respond to this challenge of malnutrition in the Eastern Cape. To cite just but a few interventions that we've put in place, the Department of Social Development, working in partnership with Health, Education, SASA, the NDA, the Department of Home Affairs, we've been implementing since 2023 a program that we call the Integrated Mother-Child Development and Support Program. And it's one of the instances, one of the interventions that were presented to the Commission in the last sitting. But the recommendations of the Commission was that this is not enough, you must do more. This plan needs to be supported, this plan needs to be additional resources, this plan needs to be cascaded down to communities. What we have since done, Commissioners, is as part of this plan, is to incorporate the Department of Agriculture, then it was called the Department of Rural Development and Agrarian Reform, and together with these departments, we then developed a rapid response plan for the Eastern Cape. And that rapid response plan basically sought to ensure that it's not business as usual, that the timelines that we had put in implementing our programs had to be pulled forward a bit. Resources that were spread across the province had to be targeted to hotspots of malnutrition as guided by administrative data that we were getting from the Department of Health, but also informed by Stats SA findings of which communities and which wards are affected by poverty in the Eastern Cape. So we've put this rapid response plan in place, and part of the interventions of the rapid response plan was to acknowledge that we are not doing enough in promoting communities and households to produce their own vegetables. And so there's a commitment in that plan to ensure that we promote school gardening interventions, ensuring that the Department of Education school feeding scheme also benefits from those school gardens, and that communities and households near the vicinity of the school can actually access the schoolyard, produce their own vegetables, and basically become less and less dependent on having to buy vegetables from the supermarkets, but that communities and households themselves become actively involved in producing their own food. And in addition to the rapid response plan, we've then adopted the Integrated Community Outreach Program, the ICROP, partly to respond to the findings of the Commission that there are communities that are located in the deep rural areas of the Eastern Cape where road infrastructure makes it difficult for them to access services of government. And if they try to do that, they had to spend a lot of money to get to the nearest offices of government. And so through the outreach program, which has since been adopted by the Executive Council of the Eastern Cape as the way to go in making sure that some services are provided into the deep rural communities, we then organize mobile services from the Department of Health. They do health screening, they do immunization, they also test for chronic conditions. We also bring in the Department of Education. The Department of Education facilitates the registration of early childhood development centers. They also identify children who are matriculants who don't have ID numbers so that they are able to sit for their exams. We bring in the Department of Home Affairs. There's registration for births. People are applying for IDs. We bring the South African Police Services, where there's a need for a commissioner of oath, where people cannot apply and they need a commissioner of oath. The South African Police Services are on site and they assist people to write affidavits so that people can actually apply for grants. The Department of Social Development runs community dialogues to identify what could be the factors that are contributing to child malnutrition, what is the extent of teenage pregnancy, and then communities dialogue. And they develop their own plans of how they are going to address the challenge of malnutrition in their locality and how they intend to work in partnership with government to ensure that the scourge is addressed. We bring in the NDA, the National Development Agency, which is an agency of the Department of Social Development. They are the arm of government that goes out to the private sector to mobilize private donations of breakfast packs. And so through this iCrop, we have tried to reach out to hotspots of malnutrition, communities that are lying in the far-flung areas, and communities themselves, they are bussed into the site where the services are going to be provided. So they don't have to pay. So we organize public transport, they are bussed in, we spend the whole day there. For this financial year, we had planned to run 52 iCrops the previous year, which is 2024-25. We ran about 56 iCrops, making sure that these services are actually provided across the communities. Let me just go back to my, sorry, commissioners. So in addition to the rapid response plan and us adopting and promoting that the iCrop be adopted as an approach to service delivery in the Eastern Cape, given the poor infrastructure development, we have also facilitated a process of actually ensuring that the integrated mother and child development and support program is monitored. For most of these interventions, including the iCrop, there are debriefings where the different government departments are then going to indicate the numbers of people that they have serviced, the type of service that they have actually provided, the age categories of the people that came to access the services, and also we follow up with our community development work post the iCrop, where then our social workers or community development practitioners will then go on and ensure that people access other government services that they might not have been able to access on the day. For example, issues of land, which were raised here, access to shelter and accommodation for those that are complaining that they need those. The work of the integrated mother and child and the rapid response plan is partly, apart from being guided by the available administrative data from the Department of Health in terms of which areas are hotspots of malnutrition, we also work very closely with Stats SA, the department, the NDA, in profiling families or households that have been identified during the iCrop as needy. We then make follow-ups to these families through our own CDPs, and what we generally do is within a household we look for a person who is able-bodied, whom we term the change agent of the household. Somebody that can then be placed within the expanded public works, social sector expanded public works program. Then they work for the Department of Social Development, doing administrative work. Others, they join in as cleaners. Others, they get placed in an NGO, if there's an NGO for persons with disabilities, for older persons, but they get placed in an NGO. And during the placement, which is normally between 12 to 18 months, they get a monthly stipend, which is compliant with the ministerial determination from the Ministry of Labor. And over and above getting the stipend, the change agent of a particular household is then taken through various types of skills training just to make sure that come the 18 months, they are then placed either in an NGO as admin assistants, or they can encourage to go back to school. Those that need to go back to school, then they access NSFAS. They are linked with SASA, they are linked with Home Affairs, but generally, through the household profiling, we then assist the household to have somebody who is then going to ensure that the family is improved on a sustainable basis. That in as much as families are going to get the emergency responses like your social relief of distress, like your medical care, but there's somebody who is then going to be the anchor who is going to assist to lift the family out of the conditions of poverty. So part of that, we are informed by the profiling that we do with health, with the NDA, and the profiles are available, commissioners, to guide the work of the departments. We are also, since the publication of the report, as the DG has reported, we then fast-track the development of the Eastern Cape Food and Nutrition Security Plan 2024 to 2030. The plan has since been endorsed by EXCO, the Executive Council of the Eastern Cape, for implementation. We then, as part of popularizing the plan and of ensuring that we get civil society to participate in driving food and nutrition security in the Eastern Cape, we held an imbizo where we invited various civil society organizations, private sector, and where a coordinating forum was established, the purpose of which is to, one, promote advocacy on the scourge of food insecurity in the Eastern Cape, two, facilitate the establishment of similar structures in all the districts, and three, ensuring that they monitor the implementation of the plan to ensure that whatever public resources that are committed towards food insecurity in the Eastern Cape, they actually go towards those who deserve. So we have this plan, supported of course by National, who funded the appointment of a consultant. Thank you to their support. But what that plan covers, it covers the work of the Department of Social Development insofar as DSD is committed to promoting household food security, making sure that people that experience undue hardship have got access to social relief. It also commits the Department of Health to strengthen their immunization campaigns, deworming, and making sure that they provide therapeutic interventions for children that have been identified as malnourished. It commits the Department of Agriculture towards funding and providing technical support towards food production. It commits SASA towards making sure that communities have got access to grants. It commits the Department of Home Affairs to making sure that communities have got access to birth certificates and IDs so that they can then apply. It pulls in the Department of Economic Development and Environmental Affairs to ensuring that the cooperatives that are established as part of this process find a way in which they get incorporated into the mainstream economy of the Eastern Cape, and that jointly with the Department of Agriculture, they will then facilitate the establishment of hubs to ensure that these cooperatives become sustainable on a long-term basis. It also commits the Department of Education, one, to strengthen the provision of the school nutrition program, to extend that program to cover early childhood development. We have since trained, we have a program to train a number of ECD practitioners, making sure that they are aware of the need for us to roll out and accelerate food and nutrition security. But over and above that, social development has got a database of a number of early childhood development centers that are not funded by the Department of Education. So it also commits a collaboration between DSD and the Department of Education to ensure that those drop-in centers, those daycare facilities that are not registered, that are not funded by the Department of Education, they benefit. I'm just trying to think now what are the things that we've done as part of this plan, but perhaps I must proceed, commissioners. My gadget keeps on disappointing me. So this is the update to the work since the publication of the report. Yes, I've covered the issue, the area of skills development for mothers whose children are diagnosed with malnutrition, the support to early childhood development practitioners to assist with the middle upper arm circumference assessment so that we have a wider pool of identifying the hotspots so that we can make follow-ups to those households. We support income generation interventions as part of DSD. Part of what we do here is there are a number of private sponsors that are involved in the clothing industry. In some instances, we set up cooperatives for mothers whose children are affected by malnutrition. We train them, they establish a cooperative, we fund the cooperative, they get taken through for some training. They then are subcontracted to produce garments, some of which have been, we understand, have been sold in New York. The other area, 2.2, that we expected to respond to, commissioners, relates to the number of food parcels that we've distributed since the publication of the report. The total number between 2023 and 2025 is 5,436 food parcels. They take the form of either a food parcel that is certain food items. Also, they include blankets and clothing, some toiletries. It's a means-tested intervention that people have to be assessed by a qualified social worker. The distribution per district is also outlined. The highest district that received, the district that received the most is Alfred Nzo. They received 1,066. The second highest is Nelson Mandela, 927. The third highest is Buffalo City, 727. And then you've got OR Tambo, Jogabi and Krisani around 600. Alfred Nzo received the list at 416. For 2024, food parcels, there is a breakdown, month by month distribution of food parcels by the department. I understand that the correspondence was forwarded to the commissioners by the HOD. So there's a breakdown from April to March 2024. For 2025-26, there's also a breakdown of how much we have, how many food parcels we have distributed. I think the figure is close to 1,400 from April to July. The list of NGOs that are funded, can I just have a copy of that? Because 669. Because the one I have here is not comprehensive. It's 669 NGOs funded commissioners in the Eastern Cape that are participating in this area of food security. The classifications are, we've got the community nutrition development centers, we've got 36 of them. We also fund community home-based carers, 87 of them. Drop-in centers that mainly service children after school, we've got 29. And then child and youth care centers, we've got 2. These are facilities that house children that are in need of care. Coordination between the departments to ensure that we maximize impact and pool resources. In this area, commissioners, we are guided by the 2025 to 2030 Provincial Medium-Term Development Plan. And in terms of that plan, the Department of Social Development is responsible for coordinating to lead the area of poverty and tackling the high cost of living. And in that regard, a cluster of departments was put together, which is called the Social Protection, Community and Human Development Cluster, which is led by the Department of Social Development. And within that cluster, we've got 3 working groups. There's a working group that looks at poverty reduction and sustainable livelihoods. And then there's another cluster that is looking at improving access to health. And then there's another one that is ensuring that quality basic education is actually provided. That one is coordinated by the Department of Education. And what we have done within the clusters themselves, commissioners, the cluster has got what is called the program of action, and some of the key priorities of the program of action of the cluster, they talk to ensuring the availability and access to nutritious food, and this the cluster is monitoring the implementation of the Provincial Food and Nutrition Security Plan. And then the commitment to ensure that we promote food gardens at a community level, as well as utilizing spaces or underutilized land in schools, ensuring that people have got access to grants. And there's also a commitment to link grant beneficiaries with other sustainable livelihoods interventions, where grant beneficiaries are actually encouraged to establish their community gardens. They are taken through skills development programs, and then they are funded by the Department of Social Development to establish their own income generating projects. And of course, the commitment is to ensure that we are better coordinated and much more comprehensive in protecting families and communities, and specifically targeting those households that are most affected by food insecurity. It's driven by profiling of households and communities. To that extent, the Department of Social Development has been given a responsibility by the cluster to ensure that we extend the function of profiling to include local municipalities. There's a commitment to rope in CDWs from the local municipalities to assist the whole of government to profile, to bring in 1 or 2 academic institutions to assist in ensuring that there's capacity building in the area of data management and data analysis in the province, working in STES SA. And then, of course, as I've indicated, the cluster has endorsed the Integrated Community Outreach Program as an approach to making sure that we are able to take services to far-flung communities. And of course, as part of that, there's a commitment to ensure that there's ongoing integrated mobilization of communities raising awareness around this issue, and then bringing as many stakeholders as we can to ensure that they also put a shoulder to the work of government. The report from the HOD indicates the number of learners that have benefited through the interventions. We've got 1.5 million that are benefiting from the National Schools Nutrition Program. We've got 114,000 ECD participants that are benefiting, and the commitment, commissioners, is to expand through our rapid response plan. There's currently, as we speak today, a seminar conducted by the Department of Education. They are looking at how better to strengthen that intervention, because it is expected that they must go back and report to the cluster, and once they report to the cluster, what the other government departments are going to do is to look at how they can support education to ensure that they are able to deliver on the commitments that they are making. Yeah, I'm almost there. I'm almost there, DG. I think, commissioners, in the area of information dissemination, part of the issues that was raised by the Department of Health is the strong correlation between child malnutrition and teenage pregnancy. And the commissioners, of course, have raised the question of, is it teenage pregnancy when children as young as 9 or 10 are affected? To what extent is the concept of teenage pregnancy blind spotting us to some of the cases of statutory rape? I think we will take that to the forum. There is a forum where we discuss with the Department of Health this issue. As part of that forum, we have also participated in raising awareness. We are part of a team that is working on the youth-friendly zones. We have a population unit which is funded by the UNFPA to ensure that we address issues of gender-based violence, female genital mutilation in the Eastern Cape, funded by the UNFPA. We have a unit within the Department of Social Development, which is the population unit that drives the program of the UNFPA in the province. And through that unit, we also participate in ensuring that adolescent sexual reproductive health and rights issues are promoted across the province. We conduct youth dialogues consistently. We also train various government officials, specifically planners from the local municipalities, to incorporate within the IDPs indicators that speak to gender-based violence, access to health, teenage pregnancy, instead of focusing on infrastructure issues. So we are influencing the thinking at that level of municipalities to ensure that they incorporate these indicators so that when they are doing an analysis, they also assist us in tracing and tracking beneficiaries that have been accessed through this program. Commissioners, I think that brings us to the end of the presentation from the Department of Social Development. I was presenting on behalf of Mr. Wachamba. Thank you very much.
Thank you very much, the commissioners. The last issue with regard to malnutrition, I think is one of the areas which we need to look at is what causes it mostly, so that we can hit it before it starts. What are the root causes of that malnutrition? But also ensuring that wherever there is food that is provided, the food safety and the quality assurance need to be looked at, and to ensure that they don't get sick by eating their food that they are given. Of importance is also the issue of the partnership that we work with. Apart from NPOs, we have got development agencies like UNICEF that assist us. And there are also other areas where we could get food forward UNICEF and other NPOs that can assist us. So let me conclude by recommending that you note the provincial and the national. Our role at national, apart from the grants, is to monitor and ensure that province does what they have planned to do, like the plan that they've been developed, and provide capacity, not to everyone, but to the Department of Social Development, so that we can capacitate them, and lastly, ensure and measure what is being done is done appropriately. So we want you to note the response. I think you received the documents, and also to thank you for standing up for the children of this country, so that government department does what it's supposed to do to alleviate any pain and sufferings, especially to our poor and vulnerable people in the country. Thank you very much.
Thank you very much, DG, and thank you also to your colleagues. I'm now going to hand over to the PM to start us off with the questions, and thereafter I'll hand over to Commissioner Makwasha. Over to you, PM.
Thank you so much, Commissioner Ntuli. Thank you so much, DG and colleagues from the provincial departments as well. DG, first of all, I just want to indicate that I know we are preaching to the converted, and that your provincial department has definitely come to the table, and we can categorically see the efforts. We've noted them, and we appreciate the steps that have been taken. But when we have to reflect and see what is the reality on the ground, that's where we perhaps have to repeat ourselves, because 3 years ago we said the same thing. We see these programs. We note the efforts. But this morning, the DG from Health indicated the numbers do not lie. The data is not lying. So I wanted to commend the efforts, because we could see the plans are being put in place. But somebody recently told me, you cannot eat policy. We've got beautiful plans in place, and I want to reflect a little bit more on the planning process, because a plan and measures being put in place takes us back to definitional issues that we are having here. When we compare Section 27 of the Constitution vis-a-vis Section 28 of the Constitution, and again we're going to have to go back to the granularities, because there is a differentiation for a reason. Because Section 28 speaks to the rights of children. We hear the planning, we hear the rollouts, we hear the grant system, SASSA registration, the bigger picture. But when we speak about the rights of children, the rights are immediately enforceable, and planning, progressive realization, and internal limitation clauses fall away. Only measured and tested against Section 36, and that's just the lawyer in me speaking. But I wanted us to start off from that premise, that when we speak about children, we need to act with urgency. And again, I'm going to commend the progressive planning and rollout of a lot of policies and strategies and movement. But Health told us this morning the numbers are not lying. So from 3 years, 3 years ago we sat here, we discussed the same issues, and I think if my math is mathing, we only improved with 9 deaths. Only 9, with the resources that we've pushed in and the efforts, Chief Director, that you've put in. We note those efforts. We've only been able to save 9 lives. And that is just the baseline I want us to move from here. So
My understanding is that there's a 37 for this grant. I'm going to go back to section 28, which says immediately enforceable for children. And I'm going to go back to section 27, which says progressively realizable. My question is, are we taking money from the child support grant, which addresses the immediate rights and needs of vulnerable children? Are we pushing this money towards the social relief of distress grant? That is my second question. So the first one, has there been an express cabinet proposal for the increase of the child support grant? Number two is, where are we taking the money from in terms of the social relief of distress? And are we in fact taking it from the CSG beneficiaries? Now, the CSG uptake for infants, we've also noted, has dropped, if I'm correct in my estimation. It's dropped, I think it's 200,000 nationally. And I think in the province it's about 30,000, let's say 28 to 30,000. In respect of that drop, which would mean there's a decreased access of this lifeline, which we're preaching to the converted here. Is there an emergency, and I don't want to say plan, because a plan, it just means we are taking steps and more steps, and by the time we get to the rollout of the steps, we have gone past the first 1,000 days that health has already indicated is the most important part of that child's life. Rapid response, Chief Director, yes, I understand. Are we rapid responding, in fact? We've only 9 lives on paper, only 9. Then we were also looking at some numbers, and that we saw that there has been a target of reaching infants below 1 has been changed to below 2. Am I correct on that? Okay, why was this specific target removed? It's perhaps also a question. Why has it not been targeted to the below 1s? And it was moved, the target was extended to the below 2s, when we know that poverty and food insecurity is rising. We know that we are aware of the fact that persons without birth certificates and proper documentation can still apply for this, the CSG. But we also know that within 3 months' time, it is then suspended, without them coming to the table with the correct documentation. If I can just be guided through why, with the administrative burdens that we know, and we even pointed it out, rural communities, mothers in the rural areas might not have access to transportation funding to get to these administrative drop-offs of documentation. There might be a delay in applying for all these documents. Is there not an opportunity for us to extend that 3 months? To still allow for this very needed support for those mothers to reach the children, to reach the caregivers, without us suspending it within 3 months. We know the administration is not necessarily responsive within 90 days, and that can place the burden, the administrative issues then places the burden on the mother, with the effect that it might affect the child. There are several other questions I still have, but I know I've got my fellow commissioners that also are very ready to jump in here. I do want to premise this, and I want us to be honest with each other. We are very clear in acknowledging the steps. Absolutely. We are clear on that. But the strategy remains in an unsigned format. Has it? I know that you're saying it's been endorsed. Has it been approved? Has it been costed? Is it being rolled out? And what is the date of that implementation? And then maybe let me just end off with 2 comments. Initially, during the inquiry, we identified, and the department as well as your partner departments identified 39 wards that were the specific areas for intervention. Now, that was 3 years ago. I want to know, with the increase in unemployment rates, the data that is available from the Department of Health, have we increased the number of wards? And by how many? Or are we still only focusing on the 39? And then my last comment and question would be to honestly ask you, and that is perhaps also the purpose why we invited not only the provincial departments, but also the national departments here today. Is this issue bigger than the province? Is the issue and the requests for intervention and implementation and intervention, perhaps budgetary intervention, is it bigger than the province can currently handle? And if so, what is our next step here? Because if the Commission is looking at the data, it is hearing the steps that you have taken, and it is reflecting on what we've heard here this morning. What else is left for us to do? Thank you, my chairperson, Askies.
In fact, I'm going to allow you, Dr. Carter, to continue with the questions that you haven't asked. And then I'll hand over to you, DG, just to address those questions before I give over to Commissioner Makwasha. Back to you.
I think, my chairperson, let's leave it for now, DG. I think I'm covered, and perhaps through the responses, if there's anything follow up and not covered by Commissioner Makwasha, I will come in again. Thank you.
No, thank you. Then over to you, DG, and then we'll hand over to Commissioner.
Thank you very much for the questions, very relevant questions. In addressing these issues broadly, sometimes as a department we find ourselves between the rock and the very hard place, or the fire and the frying pan. You raise some of the issues which I've got answer for, but I will allow teams to respond. This issue, yeah, definitely National took it upon themselves to begin to look at how can we address this. And also looking at, I don't believe it's bigger than what we can do. I don't believe that. Maybe we are not using correct strategies to be able to deal with that. If you look at the advent of disease in one of the places in the old, that was in the UK, where there was cholera. They didn't know where it comes from. They've scratched and cholera numbers were going to the hospital. Until one scientist says, okay, let me go and remove, no one must come and take the water from this place. He removed the handle of the borehole. That was the stop of the cholera. We need to identify the cause and get targeted intervention based on the cause, on who, where, and we do the what, and immediately intervene. I think it can be done that way. Both in the plan is there. Where is this? I read the report. So I will think as government or as a department plus the stakeholders, we can win this. And I think we will win this. It's just unfortunate that the diagnosis that comes from the hospital comes after the effect. In actual fact, it comes after the effect. Even when you follow on your just you refer directly to where it is, but it already happened there. What about behind where it hasn't happened? So I think there's much more that need to be done on an emergency basis, but on a targeted approach by everyone, case by case, and addressing that. That is something that National is providing guidance on that, not the plan. Plan is there. We the best in the world in policies, in development. We learn it. But the issue is to do, how do we do that in something that we need to look at it. With regard to the right of children, I think in Section 28, I think the department seized with that because, you know, the Children's Act, we are the custodian of that on the other side and both sides of it. Right of the children, there are many programs that are being implemented, which I think what happens here, it violates that in terms of what we're supposed to do. Let me, on the issue of the, is something that is the fire and the frying pan. Yes, the grant, I think he will answer. The grant, yes, the 3 months issue, they don't implement it. they wait until they're very, very accommodative in terms of that, because they are aware that it can take longer for the Home Affairs to come up with. But it also borders towards fraud and corruption. You stop following it, people, you get the fraudulent people getting the grants without. So there is it's complicated, but I don't think it's something that is not doable. We have two. The system that has been put in place currently within SASA is going to address all this issue. Biometric part of it is going to address that. But I agree with you, from the human rights point of view, you don't stop because people will suffer. But from the fraud and the corruption part of it, you need to look at what you need to do. So we won't stop it, but what we'll do is we will implement some of the systems that are there. You ask a very fundamental question, where is the 37 billion coming for? Remember the SRD came when we were in trouble, COVID. We scratched. It's not there. Every year we have to wait and request Treasury to say, are we stopping it or we shouldn't continue it? It has been seen as a lifeline for the country, for the people aged 19 to 59. It's doing wonders in terms of really addressing that issue. That's why the proposal to Cabinet for basic income support, which then will assist. Remember, the effects of the grants that we give, we are also talking about the 19 to 59 who might have children that must eat. Same thing. So we're thinking that on the other side is better identified. We will not stop one for another. We have requested Treasury. Can we get the amount? It's not only children. Even the older persons, they write petition to the minister. They want the grant to increase from 2030 to at least a living 5,000 per month. The country don't have that money. But we are saying that I think we will be able to realize it if we target the areas which is highly affected and do something about those kids. I'm thinking with the Human Rights Commission's this hearing, it also assists us and everyone else in the country to say, hey, we don't need this. And all department can put their hands on the deck to be able to deal with those challenges that we have. If you look at the intervention when a child is diagnosed malnourished, Dr. Mputeles was here. Once you are diagnosed that you are severely malnourished, it's not for you to get pap and flesh and then say you are going to go out. No. You are supposed to be given therapeutic treatment, which is meals that will be able, fortified vitamins, whatever, which is not what social development provide. Even if you can provide drugs, but not drugs, if you can provide grants for them, if they don't know what they're going to buy and eat, it's something else because it will not help in terms of that. So together, if we could focus on this, we'll be able to win that. Therapeutic treatment is given, followed up by all other government departments. That also includes that when the kids go to school or to ECD, they get fortified foods by all. We'll be able. It's one of the solutions that we have been discussing as a team to say, let's not address it individually, because you are going to give this therapeutic food, yeah, but when you come there, you eat pap and flesh. This one you gave is expensive, both of them. So if we do once, we need to have a prescription in terms of kids at this level, this is the menu that they must eat when they're 1 year. You talk about breastfeeding, and you realize it's much more. I'm just going deeper in terms of the causes. Breastfeeding will assist. Young kids don't breastfeed. The breasts need to be right, so they don't breastfeed, which is an education part of it. But if we babysit it and target it and report per head, Speetonage Pare is malnourished. What have you done to them? By all. Every week, every month, every department reporting on that. We can win that. And including others. I think even the community, they must buy on that. The CAB memo issue, it doesn't work that way mostly. You don't just go to cabinet and say, we need money on this one. We get a policy, integrated policy that we have to request every year. There's a little bit of money that is increased on grants. You are going to talk about it. It's not enough, but the use of it is something else for those that are getting it. I think we have done a lot, which I think from where I sit, it is that borehole handle removed to stop cholera, rather than going and around. If they didn't remove that borehole handle, people will still have cholera. They don't know what is causing it. It's to nab it there where it's happening, but very targeted. National, province, and everyone converge to here and say, by the way, it's not only in Eastern Cape. It's happening in other. We see Mashurumi of Kwashiorkor, marasmus in different areas, KZN. So it's something that I think as government need to focus on it and do it the emergency way, HIV/AIDS way, cholera way, malaria way, where you said this is having a problem. We are going to do 1, 2, 3, and all of us gather and do that. I think we can win this battle. Let me give my colleagues to specific. There was 39 wards. Why 39? Or what have you done? And also SASA. Over to you.
Okay, so I think DG has covered quite a lot of the responses. So on the alternative documents, we suspend if you haven't provided proof that you've applied, not if you haven't actually gone through the process. So the only evidence that we've needed to suspend, to do the suspension, is you just need to give us that slip you get from Home Affairs when you do the application. There was a period between, when did COVID start? Since the beginning of COVID up to March this year, where we didn't do any suspensions. During the COVID period, obviously because lockdown, people couldn't go to Home Affairs, and then we felt let's continue that, because basically what you're saying, you don't want to burden people that much, but then we saw a lot of fraud creeping into the system, and that's why we then reintroduced the suspensions as of this month. And so we've actually seen the numbers also on what we call the Quad 7s come down quite a lot. And that was some of the work that we had to do with Home Affairs, is also just try to reduce the risk of fraud. So as DG says, it's trying to get the balance right. You don't want to be too relaxed would be the wrong word, but you don't want to make, you need to get the balance so that those that would take advantage of the system doesn't defraud you, but you also don't necessarily want to make access too difficult for people. On the funding side, I think it's a little more complicated than saying taking the 37 or the 30, what's it now, 36 billion for SRD and doing away with that and doing an increase to the food poverty line for CSG. That's not how things play out in households. If you're in a household, you might have 2 children getting a grant, but if the caregiver is unemployed, it's not getting any grant, and if there's elderly adults in that household, that money gets shared anyway. Households don't see child support grant for child support grant. So yes, you might achieve a policy objective, but you're not really solving the problem. You have to provide a comprehensive set of grants for everybody. And that's essentially what, to some extent, it's also not enough. The COVID SRD must also be at the food poverty line, so that no household, no person, whether adult or child, in a household falls below the food poverty line. Fully hear what you're saying, Section 28, the child comes first, but again, the money in the household will be spread so that everybody gets a little bit to eat. And the 370 does also go into those child-headed households. There's about 2.7 million caregivers who get the SRD grant. So it's again a way of targeting, because the SRD is targeted at a much more vulnerable household or much more vulnerable person, that whole 36 billion rand goes to the very low income segment of the population, as opposed to if it was just broadly on the CSG, you'd get the very low income segment, but because CSG targets up to 5,600, you also get the slightly higher income groups also getting that money. So to some extent, the SRD grant does help you get more money into very low income households. And so yes, it's a very difficult policy choice. But ideally, one should try and work towards making sure that the minimum grant across all of the grants is at least the food poverty line. And the older persons will tell us the 2,300 rand is not enough, which is above the upper bound food poverty line, but there's continuous pressure as well from that group to increase that, as DG mentioned, to 5,000 rand, because saying 2,300 is not a living wage for an older person as well. So those are the kinds of difficult policy decisions DG has to, sorry, I don't work for the department, but DG has to, and his policy people has to make going forward. Do I have an option not to answer a question? The one on, I'm going to ask you to speak to the one on the outreaches that we do to try and, in hospitals, etc. The statistic change, and I know you won't like this answer, we were struggling to understand the stats. So when we looked at the Department of Health figures in terms of live births, we were achieving our targets because their numbers are much lower. When you look at the Stats SA numbers, so I think, and I don't, because I'm under oath, that I'm going to quote it very roughly. It was about 800,000 live births, if I'm not mistaken, but the Stats SA was 1.2 million. It's a huge gap between the two stats. And we just were grappling to figure out how to set a proper target. I know it's not what you want to hear, but so we opted for a wider range because administratively it's easier to measure yourself when you use a wider range, especially when we couldn't understand or get a proper understanding of the numbers in the lower range. I preferred not to have answered that one, but I know it's not the kind of answer you want to hear.
Thank you, EM, Commissioners. Access to social grants is no longer a challenge in our province at all because of the interventions that we mentioned earlier on, that we have counter services that go to all areas to ensure no one is left out. We also conduct what is called ICROPS, Integrated Community Registration Outreach Programs. I'll give some information in terms of how many have we conducted so far. At Alfrenzo, we have covered 6 so far during this current financial year. Amatole, we have covered 4 ICROPS. At Trizani, 5 ICROPS, where we also invite the minister to be involved as well to hear concerns from various communities. Joe Kabi, 3 ICROPS were conducted. Nelson Mandela, 3 ICROPS have been conducted, or Tambo 5. Number 6 is coming next week. Sahrc Malnutrition, we have covered 4. The total for this year alone is 29 ICROPS that we have covered. Over and above, Commissioners, we have improved the turnaround time from application to approval. It does not exceed 7 days. We'll make sure that within 7 days, your grant is supposed to have been finalized when you apply. And we monitor it closely, and it's one of our APP targets that we report on quarterly to National Office. But what I suspect, Commissioners, is that there is an element of abuse and misuse of children grants by caregivers. If you look at our regulations, they make provision for such instances to be reported to SASSA. As soon as we get information, we appoint an investigator through social development, a social worker, to go and undertake a home visit, look at the circumstances of that household, and make an appropriate recommendation, whether to appoint another person to take care of the affairs of that child, or to look for a community leader who's highly respected within that community, so that we remove the grant from the person who's misusing or abusing that grant, which is meant for the benefit of the child. We do look into that, but we need a specialist, someone who's trained like a social worker, to undertake the study and make an appropriate recommendation to SASSA. SASSA will immediately appoint somebody else to look into that. It goes back to what Utishi was saying. What are the causes of this malnutrition? Is it medical? Is it due to social circumstances? So that we can come up with a comprehensive, all-inclusive approach when responding to this question. Thank you, Commissioners.
The province...
No, thank you, thank you, Tichi, thank you, Commissioners. I think 2 things have been raised that the province must respond to. 39 wards. Are they still 39? No. Post-COVID, the food price increases, levels of unemployment, weather disasters, they've just changed the picture. And so within the social cluster, we normally say 39 poorest wards and hotspots of malnutrition. So to try and target based on the administrative data that we are getting from the Department of Health in terms of which communities, which municipalities, which hospitals are showing high statistics. We had planned to have a session around August where we were going to open up the provincial integrated anti-poverty strategy to revisit the concept of the 39 wards and to arrive at an agreeable figure. And you must understand, Commissioner, the idea of 39 wards is aimed at prioritizing specific communities where the problem is highest, given the resource limitations that we have. And that workshop has been postponed to October, where we will be pulling all government departments together to review the strategy and then to agree on priority communities for the 7th administration. Is the problem beyond the province? I think so. I think, as the commissioners have said, the challenge requires urgency and an acute understanding of the situation of children in the province. But sometimes that gets overweighed by the commitment to stability, to keep things as they are, because it's not easy to change with the speed at which the challenge is basically running away from us. And so you do need an outside force that is just going to nudge us in the right direction and to leapfrog towards making sure that we're able to respond to the issue. I think by ourselves, there are lots of stop and goes and potholes that limit the pace at which we should be responding to the challenge. Thank you.
Yeah, we will wait for other questions.
No, thank you very much, DG, and thank you for that very honest and transparent response. That's the aim of this exercise, to also, on our side, get an understanding of the areas where you require assistance, even where that assistance is just a nudging, a regular nudging. So thank you very much for that. It's well noted and well appreciated. I'm going to hand over now to Commissioner Makwasha to see if she has any questions. Commissioner?
Thank you so much to the chairperson, and I'd like to thank the representative from the DSD for their presentation. Like Dr. Carter, I have a number of questions, and I'm looking at the time, so I don't want to be accused of violating the right to food at a very controversial. So let me start with, I'm going to start with the report, and I like going to the report because it just highlights the importance and how far we have moved the needle. And I do agree with Dr. Carter that it's not a progressive realization when it comes to children. It's supposed to be immediate. You can't have children starving, and often what we have, and I think in my observations and monitoring of schools, where service providers are saying that even when they are fed at school, they still go to dustbins and dig in there because they're so hungry. So whilst we are sitting here and having an engagement, there's a child out there who is digging in a dustbin because they're hungry. So that's the part that I actually wanted to start on. So it says, and it speaks to the issue of what is the cause of it. It's simple: poverty, unemployment. And the representative from the Department of Health made a proposal of a grant for pregnant women. And I just want to hear what your input is, because you're not talking about budgetary constraints when we're speaking about the 37 billion. So that's starting point. Food parcels, it's nice to say what we give them food parcels, but what are the food that you're giving them? It's not just enough to give them food. Is it nutritional food? Is it valuable food? Or are we just giving them food simply for the meeting of the targets that we've given them food? I'm going to then add on to the conversation that the chairperson of the hearing stated, that we need to differentiate between teenage mothers versus children who are mothers. Clearly stated that there are children in the Eastern Cape as young as 9 and 10 who are mothers. So you can imagine one first-time mother, she's a child herself, so she is not going to have access to nutritional food, but also she's not going to be mentally ready to provide that support to her child. And I hear the programs, but how do we then ensure that
whilst we are providing support to teenage mothers, what type of support are we giving to children who are mothers? What is the role of, DSD in this process? Again, the Department of Health in their submission said, we then advise our doctors to report these statutory rapes to the Department of Social Development. How are you resolving these issues while we're talking about, decreasing the numbers holistically? In terms of the numbers, I just wanted to know how many women, if you do have those numbers, how many women are recipients of the 370 grant? Because it says, this is a report, women face high levels of unemployment, with 35.7 South African women in the labor force currently without work and actively are looking for work. And when I was reading this, I was thinking about Dr. Carter, you actually touched on it. How does the system then punish someone who comes there, says, I don't have an ID, my child doesn't have an ID, please assist, where departments are not communicating with each other? A simple cross-reference or a system that says, Department of Home Affairs, we received this application, trigger it, Department of Health, triggers Department of Education, and you work holistically. Why is it that South Africans who are living below the poverty line have to face the financial burden of departments not working together? Oh gosh, I have so many questions. Okay. Then we talk about the average food basket, and I was doing calculations, and I'm a lawyer by profession, and most of us who are lawyers, we did not become doctors because we hate maths. Now let's break down the numbers. The current grant is 560, if I'm correct, and you're saying that those who you're trying to negotiate, if they can get 50% more of that, which would mean that they'll be getting 840 rand. The average food basket, in terms of the numbers that I was given, and this is from the National Agricultural Marketing Council, currently in June of this year, just to get a basic basket, it cost 1,342 rand. Just for food. We're not considering the high cost of electricity. We're not considering the high cost of transport and rent, which a lot of South Africans are unfortunately burdened with. Now, I hear that you're saying we don't have the money. We are finding creative ways to remedy these problems. But we're not meeting our targets. You have South Africans who, despite the grant interventions, are unable to put food on the table. Have we then started thinking about approaching business, private section, saying, as Commissioner Ntuli has said earlier on, that we are wasting about 10 million tons of food? How do we get that wastage into the homes of the people that most need it? That's a creative solution. It doesn't require a financial burden. It can be a tax incentive to business. It could be, measures to control that wastage. I have so many questions, and I'm looking at the time. And the last one is, I think we're saying, has there been an audit of how the beneficiaries of these grants are utilizing it? You see on social media how certain individuals make a mockery out of it, that a mother will say, I have my child's SASSA card, but the child is living with the grandmother. Or the 370 grant is being used for buying of alcohol, and we see it. And how do we then have that audit? And I'm sitting here and I'm thinking, I know we really are stressed. We're saying we don't have the budget, but are we finding creative ways? Access to land would mean that we have school nutrition programs that are run and led by the children, who then are taught responsibility. Something creative to think about. You spoke about your programs, which I will congratulate, but I want to see real facts. Everyone listening will say, I hear the programs, and I hear that people have been targeted as change agents. Where are they? How do you change the success stories? Because we're sitting here and someone says, I've never heard this program. I'm in the Eastern Cape. I would meet this criteria, but how do I get there? How do I apply? What are the requirements? Because often the biggest issue that South Africans are saying is that government does not give us information. Are we communicating that information? Are we using radio stations? Because technology, yes, is a beautiful thing. The use of data is a beautiful thing, but South Africans still don't have access to data. Are we communicating it using a traditional media methods to ensure South Africans understand that they are able then to become those change agents in their families? And is this program temporary relief, or is it we put you in a program, we put you with an NGO, and then we see your growth pattern, and then hire you on a permanent basis, removing that need for grant and alleviating questions or issues of unemployment and poverty in South Africa. Thank you.
Thank you so much, Commissioner Makwasha. DG, I hand over to you.
Thank you very much, Commissioners, for very good questions. I will give to them what is the leftovers from me. The issue of the pregnant women grant. Long time done. We have got what we call maternal support policy. We presented it to Cabinet. They didn't say no, but when you look at the pocket of where this money comes from, it has got what you call an integrated approach. I think you were there when it was developed. So the maternal policy talks about when you are pregnant, after 3 months, you apply, so that when you give birth, that grant that you are getting, it will be equivalent to child support grant. Then when you give birth, it becomes the child's one, which is simple. Nobody will be lost. But we presented it to Cabinet. It's another resource. It needs more money, than what we have in the country. We don't have such a requirement. There is also the integrated policy for children, to map out children, what is everybody getting anywhere integrated. That can be done by a system. It's a policy that I think Cabinet have assisted because it doesn't have a cost. We have done so. Is that in terms of policy writing and things, I told you, South Africa is the best. Anything you think of, there's a policy for that already. The implementation, it becomes a problem. One of the problems is that is the resources to implement it. Because if it's a grant, remember a grant, if you say yes, you must have the money. How much does it cost? Will it be more than 37 billion? It's another area that you need to look at, which we don't have that. We don't have resources for that, so it was not approved. But there's no money for that one. The issue of the Teenage Mothers Program. There is a teenage programs. I'll read one statement which is very good, which says, as we implement this program, it says, the existing social worker services rendered to teenage parents are not necessarily based on adequate knowledge, adequate information, and understanding on how this target group cope with the issue of social, emotional, psychological, and economic consequences of teenage parenting. We have got a program which when you evaluate, we find, yeah, we are doing it, but these kids are different. The kids of today are not the kids of the old, different. So there is a program where children are taught how to care for the children. Even when you present yourself to the health facility, DST, they will refer it to social development at a local level, where they are taught and they are given education, but it also need parents. Remember, these people have got kids, have got mothers and fathers, which must take the responsibility. And we have got what you call a families program that we provide to the father, let alone the absent fathers. but the mothers are taught on how to care for the children and the families. And those are the things that the DST is seized with, using the social workers and the other people that we have. The issues of food basket, we have got costs. The food basket is 1.3, it goes up to 1.7, depending on what area. The cause of malnutrition varies in different areas. And I think on my proposal, which I think is a call for us to deal with, we will need to go deeper. What is the cause of this? What is cause of these malnutritions that we have? What we're seeing when they go to the clinic with severe malnutrition, then they get admitted. Sometimes could not be the cause that there's no food, is eating the right food. Sometimes it's neglect. Sometimes it's other things, psychological things, the family issue. There are so many causes of this that it need to be nipped in the bud, that we need to deal with that. The studies on the SRD was done. There's a study that has been done. 80, and I think it's more than 80% of the respondents to the study, they use SRD for food. Food. They buy food. You ask how much do you buy for 370, but they buy food with that food, that amount of money that we give them. And it goes a long way. In other people that are clever, they even become small business people. They don't use this one. Certain amount they buy things and sell, and they get something out of it. Those that use that as a resource to springboard what they are supposed to deal with. Food wastage is very easy to, I think, from bigger organizations and the retail. We had a program, this program called Community and Nutrition Development Programs that we have. Food, we have food banks. In the 2001 and 2, there was a program which the department implemented on household food and nutrition program, which is the food banks. There were NPOs that goes and collect food from Pick and Pay that are given. They'll give you whatever, jig, doom, plus food and other things. But some of the food were expired, which cannot be consumed. Some of the food are not really fit for human consumption because it will be the fresh food that you don't eat. Let's say, for example, we are going out for lunch, we leave this food and we give to someone else, become the cause of disease. So we implemented that program very well. But community themselves will say, why do you give us leftover food? Why do you give us old food that expires? There was even an article, DST feeding people with expired food. And it expires. Remember, they will get it when there's 7 days or 14 days of expiry. By the time they get it, has expired, which there's a grace period of 7 to 14 days or 30 days. We implemented that program as a way. This program, which we have, household food and nutrition program, started with food banks that were, there was an American company that was here, food bank collecting food from Pick and Pay and providing to everyone. But South Africans stood up very harshly. No, you can't give us food like that. So we then say, no, we're going to use our taxpayers' money to buy food. And that's what we are providing. The food that is used, we provide to families. Sometimes when you are poor, you don't have resources to cook it unless you are in vendor. Where I come from, you just go get a old tree, bring it, you cook. But when you're in the township, there's nothing like that. So some of the people, even you give food parcel, they won't be able to use it because it needs to be cooked, and they don't have money for electricity to. So it's a chain. That's why the establishment of the Community Nutrition Development Center, just go and eat and come back. Food will be cooked nicely. That's as one option, not as all the options that we have. The programs that we need to have, I must say, really, human rights commissions and the commissioner, you are on the right track. But we also, as government, need to really go deeper in terms of what we can do. I still stick to my story, cholera in the UK. Remove the cause and deal with what's supposed to be done directly to a person, to a family, with the name and surname. And I think we can be able to deal with that. If you look at how SASSA does things, they'll give you the name of a child who is on the ground where the child is. Other departments need to come on board on the same, and we focus on that, and so that it's not only 9 lives that we save. We can save all of them if we know who are these people, where do they stay, and what are we saying as a province, as national, to deal with those people and report back to the human rights the same way, which I think in the next request for you, you must tell us, okay, Health gave you the statistics today, but they must give you the names and the IDs and the place where they stay, so that we can be held accountable to say, Peter, did you go to Peter's family? Did you address that question? If we do that, we'll be able to deal with that. Not a policy, not programs, but dealing with the question that is. And I think that those are the things that we require. If you look at how we dealt with HIV and AIDS, it was not just, you come and test, and we said, it's red, my brother. Red, yeah, you must do something, not anybody else. You must do something to deal with this issue. And it becomes a notifiable medical conditions that you need to do. And it is in that line that I think in the next reporting that I'm requesting is that we need to bring, you get the names. Okay, it is in this district or this local area, ward, there are 25. What are their names? Then we come and account, what did you do to the 25 in Ward 7? What is the progress on that? The last part is that the statistics at stats is, remember, it's an overall figure, but I think the health, they give you the right stats because it's for the person that comes to the clinic and is recorded, which I think that we must use that from that area. Thank you very much. I think I've answered all the questions.
No, thank you.
That's question? No, if you...
Please go ahead.
Yeah,
there was a question on how many, the gender breakdown for the SRD stats. So we currently have roughly 9 million approved applications, of which 4.7 million are female and 4.3 million are male. So it's 52% female, 48% male. And then, as I mentioned earlier, of that 4.7, 2.7 are also recipients of the child support grant. I don't know if you want it specifically for the Eastern Cape? Okay.
I think we're done.
No, thank you, DG, and thank you to your colleagues. DG, there are a number of areas where we agree with you. And the main one is that South Africa is a champion of law and policy. If I was an alien and I didn't know the situation in this country and I just read the laws, I read the policies, I listened to your beautiful presentation, I would say there's no problem in this country. Yet the reality is that we are amongst the most violent society in the world. We have the highest rates of inequality in the world, highest rates of gender-based violence and femicide. Children are dying of hunger. As Dr. Carter said earlier, It's all well and good to hear this presentation, but the numbers don't lie. Given the presentation of earlier today and the presentation we've received now, the situation, save for the 9 children that make the difference between 3 years ago and now, the situation is deteriorating. So all of these interventions are just words. We clearly from the presentation are encouraging a culture of dependency, which is also inherently contradictory. The state admits that it doesn't have the financial resources to sustain this culture of dependency, to continue reacting to poverty and need by dishing out. At the same time, we all agree that this is a problem that should not be a problem, because South Africa is rich in land. South Africa has amongst the best climates in the world. We feed the world. The majority of the food that we produce, we export. Yet we fail to feed our own children. So this is not a problem of resources. It's a problem, as Commissioner Makwasha has said, of how we manage these resources. It's a problem of creativity in the ways in which we think about our constitutional and legislative responsibilities. You mentioned to us, amongst the various programs, that you have a nutrition program of food production in schools. Now you have that program, but you also have a feeding scheme program, where the majority of that food from the feeding scheme is not coming from the vegetable gardens in the schools. Now, whose responsibility is that? Because that food must be paid for by the very money that we don't have. Yet, we visit schools, as Commissioner Makwasha said, in the fulfillment of our own mandate. Schools have land that is unused, green fields that are unused. We grew up in a situation where it was mandatory as part of the school program to be involved in the school food production program. We were taught a relationship with the land which is no longer being taught to the children. We cannot expect the children to teach themselves. We have a responsibility, and when I say we, I mean the state, have a responsibility to marry the discourse of a lack of financial resources with equal innovation and creativity. If all of the schools, DG, in this country used a patch of their land for a vegetable garden, which in turn would then be used by the local women and men, so that we don't gender the role of cooking. The same food, you have a food patch, you have a seed bank in the school, so that you don't have to be buying seeds. You generate the seed bank through the seeds that you produce here. The community cooks and feeds these children. Then you end the problem. And you can then invest these financial resources that you are investing in this problem to fixing other problems. But we are not thinking out of the box. We are writing long strategies and policies and CAB memos that go nowhere in terms of the reality on the ground. So, in essence, DG and colleagues, we are very grateful for this presentation. But until these discussions translate into equal measure on the ground in terms of children that are going to bed not hungry, schools that are green with food, then all of these efforts are meaningless. So the question for us is, what is the Department of Social Development going to do about ensuring that it fulfills its own responsibilities to address and end these problems? We cannot be here 3 years after the inquiry, DG. There's no change, but we are spending 3 hours on a discussion around very beautiful presentations. So those would be our positions as the South African Human Rights Commission. I will now, DG, I don't have many questions. These are just my own reflections. I've been covered by the PM. I've also been covered by Commissioner Makwasha. I'll give you the opportunity, DG, to offer us your closing remarks and also just some reflections on this challenge that I'm posing to you, to say we have a problem that is not a problem, that should not even be a problem. And we are thinking about solutions that require resources that we don't have. And we are leaving the resources that we do have. We have land. We've got food. We've got seeds. We've got hands. We've got highest rates of unemployed youth that could be tilling the lands in the schools. We come from cultures of communality, of Ubuntu. Children should not be starving and dying of a lack of food. Over to you, DG.
Thank you very much, Chair and members, Council. I think my parting shot will be we really feel very challenged, and so it is only when you come and you ask these questions that you realize that I think we as government miss some points. We miss the targets, and that we accept the challenges that you have brought to us, which I think from the Human Rights Commission saying, what is that we are going to do? Whether what we are going to do has got an impact on people, and how will we know? Because the outcomes that we see is not favorable. It is time that I think as government, that's why I propose something very drastic. I think I will write something to you, just advice so that I can get. We feel so challenged, and we are going to do better to implement the program that we have differently. Differently meaning, I don't think the challenge that we have with malnutrition as it stands is unsurmountable. I think we can win this battle. I'm very optimistic that we can win the battle if we do it right. We have accepted the challenge, and I think when you come back next time, after I've written, I'll write something to say how we should account, especially on this issue. My proposal and what I'm saying to the team and to the province is that I think let's use another strategy to address the challenge. I'm proposing that we use the strategy of be giving the names of those kids and families and the wards. And then when we report, we must tell them family 1, no more malnutrition. Family 2, and any other areas that are having those challenges. And I think the second thing that we're proposing is an integrated approach. You are bringing us here together as government, bring education, bring health. Then it's the same way as when we go, we take them to say, what do we do? And then how we're supposed to do it. And I think a plan, next time, it must be a united plan than the one they have. But this will be a reporting to tell, this is what we find, this is what the health have done, this is what DSD have done, and each province, or here it will be the province, Premier owns that report of the issues, and we monitor it over a period of time. It was very challenging to be told the whole 3 years we did only we saved 9. It might be that we saved 9 because the other one didn't come or they didn't go to the hospital to be diagnosed. So I think it's a challenge for us as government, and it's something that we need to change and do things differently, use different strategies that we can do to tackle the challenge. We are going to report differently. We've got a role as national to monitor the implementation. We also have got a role to make sure that we develop a sound plan and strategies that are implementable. Some of the things doesn't need money. You just need to do the right things with the little that we have so that we can achieve the best, so that our communities can get what they are getting. I need to stop here and say thank you very much. We are doing a lot, but I think having seen the challenges the way you brought it to us, it calls for us to do it differently. What difference do we need to do to be able to, what strategies and what is that way, how should we do what we are supposed to do to achieve the best for our own people is what we need to focus on. Thank you very much.
No, thank you very much, DG. We appreciate this attitude. We appreciate the tone. We appreciate the care that we can hear in the ways in which you are attending to the challenges we are bringing to you. Thank you very much. As we indicated earlier, ours is to work together with you because we have a common client, which is these children, which is our society. Therefore, it's in our best interest that we work together to ensure that we meet the demands of the day, which is the protection of human rights and the preservation of life, most importantly. So thank you very much, DG. We are very much welcoming any opportunity for you to just bounce your ideas with us. Think outside of the box. Ask yourself, is this something that has already been done and failed? If so, then don't try it again. Think outside of the box and bounce ideas off us as the Human Rights Commission. We welcome the opportunity to engage with yourselves, to add to creative and innovative ideas. Certainly in the next financial year or 2 financial years, this will be a problem of the past if we work together and hold hands. So thank you very much once again, DG. Thank you to your colleagues. We appreciate your time. The time is now 5 minutes after 2 o'clock. We are going to go for lunch. Our engagements with yourself, DG, are officially come to an end, but of course, if there are any follow-up questions, we will write to you, but also you are at liberty to also engage us on your plan. You are at liberty to engage us on any other matter that might be of importance as you think about strategies to end this problem. I will hand over to the PM to just guide us on the time that we are going to have for lunch. And please, you are welcome to lunch. As Commissioner Makwasha is saying, the right to food is very important to us. Over to you, PM.
Thank you so much, Chairperson DJ. We will be breaking for lunch, and we do apologize. We recognize the Department of Education is here. We are running about 30 minutes late, and we will try and make up for that if we can break for lunch. It's in the dining hall inside of the hotel, and we be back at 2:35. Are we rushing a little bit? No, 2:35 to make up as much time as we can, and we apologize for the delay, but we do think these are very necessary conversations to have. So with that being said, thank you so much. Everyone's welcome to come and join us in the dining hall, and we will be back at 2:35. Thanks. I'm the Provincial Manager. For those who are only joining us now, we are in the second session of our subpoena inquiry into malnutrition within the Eastern Cape. This morning we have heard from the Department of Health, we've already heard from the Department of Social Development, and we will now be proceeding with the presentations from the Department of Education. With that being said, I am joined by the chairperson of this panel, Commissioner Pilile Ntuli, as well as Commissioner Makwasha, and I will be handing over to Commissioner Ntuli for a brief remark before Commissioner Makwasha will be administering the oath for those who will be presenting on behalf of the department this afternoon. Thank you so much.
Thank you, Dr. Carter. Good afternoon, everyone. We are still observing the same rules that we have been observing the whole day, which is that once we are back in session, we respect that there's only one speaker in the room, and if there's anything urgent that we wish to convey, then we can indicate so and we'll be allowed to speak. But for as long as we're in session, may we kindly ensure that our devices are off, and when they need to be on, they are on vibrate. And if there's anything urgent, we write a note, or then if it's more urgent than that, we indicate as such. As Dr. Carter has indicated, my name is Pilile Ntuli, and I'm a commissioner with the South African Human Rights Commission. I'm chairing today's subpoena proceedings, and I'm joined on my left by Commissioner Sahrc Malnutrition, who is also a commissioner of the South African Human Rights Commission. We are very pleased to be joined by yourselves, colleagues from the Department of Education. As you are aware, what brings us here today is a subpoena notice that you would have received that outlines the topic of the day, which draws its reference from the inquiry on child malnutrition and food security/insecurity in the Eastern Cape in particular. The report was released in September 2023 with specific recommendations, and our job in terms of our constitutional mandate is to monitor the implementation of those recommendations. We of course are concerned by the, am I still on? By the rates of implementation of the recommendations of the report, as evidenced by the numbers. Children are continuing to go to bed hungry. They are continuing to suffer from malnutrition. And of course, the education department and the education sector has a critical and central role to play, because many of these children are at school. Many of these children are, for the majority of the hours that they are awake in a day, are under the guardianship of the department. Therefore, you have a critical role to play in this discourse. I'm now going to hand over to my colleague, Commissioner Makwasha, to administer the oath, after which we will then hear from yourselves your responses to the notice that we have submitted to you. Thank you so much. Over to you, Commissioner.
Thank you, Chair. Just so that we proceed, can I kindly ask you just to stand, or perhaps let me just start by saying which of you will be making the presentation? Both of you, or just one gentleman? All right. All right. Are you authorized to make the presentation, or have you been properly mandated in terms of the letter?
Yes, ma'am.
All right. Can you just kindly stand so that you can take the...
Yeah, just to also indicate to say there are two presentations. The one that I will be making is from the Department of Basic Education at National, but the province has also prepared a presentation that we agreed that they will provide most of the details on that one.
Is there a representative from the provincial department?
We are expecting them to be in the house. We don't know what happened.
Were they here?
I didn't see them.
Dr. Carter, have they been properly subpoenaed?
Yes, there was indication that they were outside, but they are not picking up their phones, but I think it will be
What we'll do, I don't know, Chair, if you can just guide us on how do we proceed, because the national department is here, but the provincial is not here.
Could I get clarity again? Where is the department? The provincial department? You have not been in communication with them? Not today. This is resultant from a provincial inquiry. While we appreciate the role of the national department, it becomes of critical importance that the provincial department is here, because they're at the coalface of interacting with these issues. It's been made very, very clear the prevalence of the issue in the Eastern Cape, particularly in this metro. In their absence, it becomes almost impossible for us to proceed. It's obviously highly disappointing that they are unable to be here today. The notice was issued to them.
They will send a letter, and we've got a nod in the house there. So are you from the department?
Nationally as well, same with them.
Oh, okay.
But our point is that we communicated with the office, they are aware of the invitation, and we felt the non-initial was because I said the initial.
Yes, I recall. Yeah.
So our initial find out was that they were meeting someone in one, and we were told that there was no contact. Like that question. Yes, of course,
Thank you. So quite clearly, it's not because they are not aware that they are supposed to be here. They are just not here because they are engaged elsewhere. We will not proceed in their absence. So we'll await for your colleague to come back to us to indicate what it is that is being communicated to him, and then we will take a collective decision as a panel after we hear from him. Thank you. You have been invited to perhaps just provide clarity for us in terms of the expectation this afternoon. It was the provincial department would be represented by the HOD supporting the national department to this engagement. Are you able to perhaps just clarify for us what the situation is at the provincial department?
Sorry. My apologies. Good afternoon to everyone in the meeting. My name is Lulamani Zenzile. I am from the Eastern Cape Department of Education. I hold the position of a Chief Director for Learner Development and Social Support Services. I'm here, ma'am, just to provide a clarity as asked. We were supposed to be here at 2 to attend to this commission, and Mr. Jwagadi, whom was delegated to lead the discussions of today, was chairing a session in one of our institute here in East London. And perhaps there has been some communication because we were to be indicated as to when we are needed, so that we prepare as such and come and attend to this commission. The HOD has delegated Mr. Jwagati to come and lead the delegation. I hope my answer is enough.
Thank you very much. So are you able to indicate where that delegate is?
Thank you, ma'am, once more. I had tried to get in contact with Mr. Jwagati. Perhaps if the commission allows me just to check on my phone if he has come back to me, because at the time I was entering the door, my phone was ringing and I could not answer. With due respect, I didn't want to disturb the session.
That's fine. We will then just stand down for another 5 minutes to give you the opportunity to try and get hold of Mr. Jwagati and get an indication of where he is. Thank you so much. Thank you very much and welcome. We had paused the proceedings to ensure that you are with us this afternoon. We welcome you. We have introduced ourselves. I am Pili Lenduli. I'm the Commissioner for the South African Human Rights Commission, and I'm the chairperson of this subpoena hearing. I'm joined on my left by my colleague, Commissioner Sahrc Malnutrition, who is a co-panelist as well as the Commissioner of the South African Human Rights Commission, and also on my right by Dr. Eileen Carter, who is the Provincial Manager of the South African Human Rights Commission in the Eastern Cape. We are here because the Commission has issued a subpoena notice to the Department of Education in lieu of the challenges that we are facing with the rate and the pace of the implementation of our recommendations, which flow out of our inquiry report, which inquiry was held in 2022 on child malnutrition. We are therefore at a time where Commissioner Makwasha will swear those amongst you who will be making submissions this afternoon. Thereafter, we will hear your submissions in terms of the responses to the subpoena notice, after which we will engage with yourselves. I will now hand over to Commissioner Makwasha.
Thank you to the chairperson of the subpoena hearing, Commissioner Nduli. As I was saying, that we have now identified the representative from the national department. We were waiting for the provincial representative. As the chairperson had clearly indicated, I was busy with the swearing in of the witnesses. I'll start with the provincial. So can you just kindly stand while you take either your affirmation or oath? The national, apologies, we'll start with the national, yes. You may just start by introducing yourself for the record.
My name is Mr. Moses Tendindlovu. I'm the Chief Director, Care and Support in Schools in the Department of Basic Education.
So will you be taking an affirmation or an oath?
I'll be taking an affirmation.
First one of the day. Do you affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? If so, just say, I do, and raise your right hand.
I do.
Thank you, sir. You may sit. On behalf of the province, can you just kindly introduce yourself?
My name is Raymond Joakati. I am the Deputy Director General responsible for Curriculum Services, Eastern Cape Department of Education.
So will you be taking an oath or an affirmation?
I will.
Beg your pardon?
I will.
Which one will be taking? The oath, where you say, so help me God?
The oath.
Okay. Do you swear that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? If so, raise your right hand and say, so help me God.
So help me God.
Thank you. Chair, they're all duly sworn in.
Thank you. Will the two gentlemen not be making any submissions this afternoon?
So Chair, just so that we're clear, so we've got one submission that we'll formally make, that he will do, and will be part of the engagement.
I see. DG, we would need to swear you in.
That's fine.
If you are going to be responding to any of the questions, even if he is the delegated official that is going to
That's fine.
So I'll hand it back over to Commissioner Makwasha to swear you in.
Sure. Yeah.
You may just introduce yourself for the record.
I'm Granville Whittle. I'm the acting DG for basic education at the moment.
Will you be taking an oath or an affirmation?
An affirmation.
Do you affirm that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? If that is the case, just say, I do, and raise your right hand.
I do.
Thank you, sir. Full names for the record.
My name is Lulamani Zenzile. I'm the Chief Director for Learner Development and Social Support Services.
Will you be taking an oath or an affirmation?
The oath, ma'am.
Do you swear that the evidence you shall give will be the truth, the whole truth, and nothing but the truth? If so, raise your right hand and say, "So help me God."
So help me God.
Thank you.
No, thank you very much, colleagues. Then, as indicated, we'll hand over to yourself, DG, and through you, then you will delegate the official who will make the presentation. Thank you so much.
Thank you very much, Chairperson, and thank you very much for inviting us to come and respond to this particular report today. So Mr. Ndlovu will do the presentation, and of course we'll be open to the engagement.
Thank you, DG, and thanks, Chair and commissioners. Let me first appreciate the questions or the responses that have been requested of us. We know how critical the matter on the table is, especially when it comes to providing, in our case, providing nutritious meals to learners to curb malnutrition, undernutrition, micronutrients deficiency, and overweight and obesity when the learners are under our care. Let me submit that we did submit a report after the report was released. We submitted a report through, which was dated the 3rd of November 2023, where we provided some updates in terms of some of the issues that were raised in that report. And despite the challenges that we are facing, we also need to indicate that as basic education, we have managed to contribute towards addressing these challenges. And we've seen an incremental funding from the National Treasury when it comes to the National School Nutrition Program, as we progressed from just feeding learners cold meals to providing warm meals that ensured that there are quality in terms of providing the necessary nutrients that are needed by the learners in schools, which the menu also improved from just providing starch and also fortified drinks to ensuring that the menu include protein, starch, vegetable, and fruit. And also appreciate the challenges that come with the function shift of ECD from the Department of Social Development to Education, and also to share the efforts that we have taken as a department to address nutrition in terms of and the benefits that it brings to under 5. So in addressing the malnutrition in the province, specifically working jointly with the Department of Education in the Eastern Cape, we have been, in the first quarter of this year, we have fed over 1.5 million learners in 4,876 schools in the first quarter alone. And the numbers that I've included learners in grade R that are enrolled in main schools. And in terms of like the midterm budget allocation, there has been an increase in the budget to ensure that we meet the demands of the feeding learners in schools. For 2025-26, it is over 1.8 million in 26-27 in the MTF, it is 1.884, and then we are in 2027, it is over 1.9. So this shows the efforts of the department working with Treasury to try and ensure that we provide nutritious meals to learners in schools. And we have moved since 2021, where we are now also providing breakfast and processed chicken liver. The National School Nutrition Program has diverse high-protein lunch that is meant to address...
I'm sorry, Mr. Ndlovu. Apologies, Isbalkul. We were just requesting a copy of the presentation. I'm aware that it's flighted, but as the panel, we don't have a copy of it. And because this is behind us, it's difficult for us to follow. If I could just ask you to send it to one of the colleagues, they will then be able to share it with us.
Thank you, Chair.
Thank you. No, thank you. You may proceed. Thank you so much.
Thank you, Chair. Okay, sorry. Thank you, Chair, and apologies for not sending the report or the presentation in advance. As I was indicating, Chair, to say further efforts to address malnutrition, undernutrition by the department is that through the National School Nutrition Program, we have a diverse high-protein lunch that is meant to address these issues and hidden hunger. This includes the pilchard, amasi, NSNP-approved soya beans, processed chicken livers that are being faced in the 3 districts, that is Sahrc, Amatole West, and also Alfred Nzo West. And will be rolled out through the entire province to replace the chicken that has less micronutrients. And universal breakfast has been rolled out to improve the energy uptake and micronutrients deficiencies as it is made from fortified maize. And these Chair and Commissioners were working with the Department of Health in terms of ensuring the quality of the nutrients and also the standard, and also in terms of like how we package it to ensure that a learner or anyone who is in schools who is fed, we make sure that they get a nutritious meal to also make sure that we combat the stunting. And as we appreciate the challenges that come with the function shift, as I indicated earlier, we can report that the ECD has received a historic funding injection to early learning of 10 billion, and part of that funding is going to the nutrition pilot, which increased from 197 million in 2024-25 to 230 million in 25-26. So the department is currently working on advertising a tender on ECD nutrition support project this year, to be implemented in the first term of 2026, and the
budget is as indicated below, to say in 25-26 it is 236, in 26-27 it will be 249 million, and up to a total of 746 million. And also to indicate that that pilot will be done in the Eastern Cape in Matatiele as part of responding to the report from the Commission. And with the ECD centers, who are seeking to enable the centers to be able to provide nutritious food to children, so where we have a potential to eliminate at least a stave of hunger and improve the nutritional status of children, and also to contribute significantly to the physical and mental growth, health and development potential of our children, and also enable the practitioners to attend the children's needs more holistically, Chair. And I think the last 2 points in terms of like the weekend and holiday feeding and the breastfeeding, in line with the national treasury allocation, the budget of the NSNP unfortunately is aligned with the school days. It does not include weekends and school holidays. Just to refer to say, from 2021 during COVID-19, we had similar challenges, and the court accepted that feeding during school holidays and weekends is the responsibility of social development because of the financial constraints that we have, as we see the high number of enrollments in schools and also the shrinking fiscus. However, Treasury has done a good work to ensure that we meet the high food prices or inflation of food over the years as one of the challenges. The Department of is also part of the National Food Security Plan. I think some of the presentation from the Department of Health and Department of Social Development alluded to say we have an integrated approach whereby other departments like Department of Social Development will cater for after school weekends and holiday feeding that are encouraged to cater for such learners. And in some of the discussions that we had with Social Development, it is just improving the collaboration between the departments and also ensuring that some of these families that these learners are coming from are enrolled and registered to this program. As one of the discussions that I remember is that when one of the debate or the bone of contention was that if we take the National School Nutrition Food budget and also procure parcels for learners to take home, it is double dipping, as some of the families are also benefiting from the social Department of Social Development programs. And same with the school feeding, breastfeeding, to say the Department of Health is also covers antenatal and also postnatal feeding, and responsible for the first 1,000 days of the life of a child. And breastfeeding is included in such programs, and we also partner with the Department of Health in the integrated school program. And Chair, I submit that if there's any document that is needed, the Department of Basic Education will definitely make those available. I will now hand over to my provincial counterpart. Thank you. I submit.
Thank you, Chair. Just fierce apologies, Chair, for the little mishap. We were waiting for the meeting, sitting next door. So then I had a meeting with deans of faculties of education, just had to close. And I felt, if you still continue with social development, let me run. So as I was running, I was called back to say, hey, come back, its session has started. So I'm sorry for that. It was never intentional. Chair, I'm just going to take you through the initiatives that we're busy with to deal with the issue. and it's just a little bit of background, and then the provincial context of Eastern Cape, the strategy of provincial government to deal with issues of poverty and malnutrition. But I can go for here as well. I'm sorry. As well as the anti-poverty strategies that we are embarking on currently, we are taking into account that we will receive from the national fiscus through the conditional grant. That is the mainstay of education in terms of child support, especially the school nutrition program. But in the rest, to also work through the cluster system in the province. Chair, the Eastern Cape probably is exactly as explained by the Commission in terms of conditions, and particularly testimonies that were given, in terms of the state, of children and cases of malnutrition. And we also note the inquiry that you went through. We then noted the basic recommendations that were made by the Commission to the province, particularly increasing the subsidy if there is possible, or extension of the NSNP to ECD. What we wanted to do is to provide a little bit of context to the Eastern Cape. It's high poverty, unemployment. It's one of those provinces. Historical legacies of homelands, very rife in here. We have a feature of child-headed households, which is also impacting on education in a very big way. But also, we have a migrating population. So the net loss of our population over the last 5 years to the two provinces in particular, Gauteng and Western Cape, is quite phenomenal, to say the least. Between 2002 and 2025, I should think the Eastern Cape population has gone down to be number 3 when it was number 2 initially, after KZN. Gauteng has overtaken us, KwaZulu-Natal, as well as now Western Cape has overtaken us, which impacts on the equitable share that comes to the province because of the population reduction in the province. The age group that we're dealing with, if you look at the 0 to 4, that cohort is almost 50% male and 49% female. Again, age group 5 to 9, it's mainly categorized by more males than females. But as you get down to the higher grades, then the number of female learners becomes more compared to number of female learners. I won't bother you on the migration pattern. As I've said, we are mainly migrating to Western Cape and Gauteng. That's where the biggest recipients are in terms of population of the Eastern Cape. Now, what happens is that we are working with social development to look at how then can we mitigate the impact of some of these shifts in our population dynamic. As a result, if you look at the child support grant and the number of children that are captured by child support grant in the Eastern Cape, which also gives the context to the Eastern Cape, and we've just given the age groupings and the numbers, and Eastern Cape is one of the highest numbers of children who are beneficiaries to the child support grant. I'm sure the Department of Social Development would reflect the same statistics as us in terms of one of the social networks. We are characterized by children who are orphaned. And if you look at the shifts between 2002 and currently, just under 5% of our children are orphaned, which is almost a big, aspect of the population of children that are living with us. Children not living with biological parents in the Eastern Cape, again, you will look at 2002, the numbers were lower, just below 30%, and currently they are just above 30% children in the Eastern Cape that don't stay with their parents. Then the percentage of distribution of female-headed households in the Eastern Cape is one of the highest when you compare to all other provinces, which makes the Eastern Cape case much more acute. Now, the population dynamic of Eastern Cape is such that 30% of the age group 15 and below, they reside in the province when you compare to other provinces. So we still remain the highest. So the biggest could be, in terms of comparison, Limpopo, but in the main, Eastern Cape, KZN, we still have the highest number of population below age 15 that reside with us. What we've done, Chair, through the cluster system is to work out on a number of poverty alleviation trajectories, for the province, trying to make sure that we reach the entire population. Now, we did take stock before dealing with the 7th administration requirements and strategic priorities to look at what we've learned from what we've been doing for the past 5 years in the 6th administration. And there are lessons that we came up with. The first one is that I should think we're characterized by silo planning and silo budgeting. Whilst we're preaching, integration, still our budgets and management of our delivery programs were characterized by silo planning. Then two, I should think there was a lot of double dipping in policy implementation, particularly social protection policies. We picked up there's quite a lot of double dipping. And despite all of these improvements, I should think there was still a lot of issues around management and administration of poverty alleviation programs, which had a huge impact. Last but not least, in terms of lessons that we've learned, is the prioritization of social budget of budgets generally resulting in underfunding of social priorities in the province. Again, Chair, I'm not going to go you through the list of all of these, just to say that the cost of doing business has become higher. These are the lessons. So what we did in the process was to redesign our social protection strategy as a province, just to look at how much can we deal with issues of managing high levels of poverty, malnutrition. Problem statement is the usual, just statistics and who's, where, and what's happening, in terms of food security in the Eastern Cape. Problem statement, again, looking at efforts that we've done to improve the situation. But key and critical are the commitments of the 7th administration in the Eastern Cape. One is to ensure no one lives below the minimum social floor. Number two, all children to enjoy services and benefits aimed at facilitating access to nutrition, healthcare, education, and social care. Dealing with issues of hunger and malnutrition, especially among vulnerable groups. Looking at the skills deficit in the social sector, providing income support to the unemployed, creating an effective social welfare system. So these are the, sort of sector priorities as we look into the 7th administration. We then integrated them, Chair, into 9 integration areas that are looking at the vulnerable, and we are looking almost the entire coverage of social protection programs, not only, malnutrition and hunger issues. The first one is inclusive early childhood development. Second one is municipal support. The third one is social cohesion. The fourth one is anti-poverty. And that's where the gist of our programs lies, on the anti-poverty working group. Fifth is infrastructure. Sixth is land reform. Seventh is inclusive economic growth, non-communicable diseases, which is more health, as well as transformation programs looking at youth. We then agreed, Chair, that in each of these, especially the one that deals with poverty alleviation, we will have indicators that we will be chasing as a province, and this is almost an illustration of the program of action that we have embarked upon. And when you look at it, it's almost an articulation of who does what when, and I'm not going to bore you much on that. But in its implementation, what we had agreed upon was to look at targets that we must chase, and therefore look at what is achievable per quarter. In here, we look at the manifesto of the party. We also look at the draft medium-term budget frameworks, and we look at the focus area, and then we state what is it that we're going to be dealing with. Issues of malnutrition. We have set up targets just across the social sectors. I'm just taking you through because it's a program of action of government. Now, changing the anti-poverty trajectory of the province required us to look differently, particularly programs that are focusing on sustainable rural livelihoods, managing, especially breaking the cycle of poverty through human resource development. That's been our task. Then we agreed on inter-cluster collaboration So in the intercluster cooperation, we're looking at food security, social infrastructure, capacity building, as well as post-education and training. The scope, approximately 1.3 million children are covered by the Child Support Grant in the Eastern Cape. And I'm not saying, Chair, the reach is reaching to every child, but of all the children that are school-going age, 1.3 million out of the 1.9, 1.3 million are covered by the Child Support Grant. 1.6 million of these children are receiving a hot meal through the nutrition program of the department. 200,000 of these are covered by the Child Foster Care Grant. And then 2/3 of these children, they receive some kind of income support. But in the overall, these are the kinds of programs that we are dealing with. The NSNP, which is the biggest of our grant as education for poverty alleviation, and this is the scope of the definition of the NSNP, but the allocation, it makes sure that 97% of that budget goes to the feeding of learners, and only minimal that goes to administration costs, and in this case, is 2.5% admin, is 0.2% education, 0.3% on the utensils. But the mainstay of this program is financing the feeding of learners. Now, if you look at the numbers that are fed by the grant in the province, 1.5 of these learners are in the main meal, and 1.5 of these learners are now getting a breakfast. So they're getting 2 full meals a day. It's a breakfast as well as lunch. And then 326,000 of these are benefiting from what we call chicken livers pilot program. And I should think colleagues from DBE have spoken about it. Now, of these, there are 6 districts of the 12 districts in the Eastern Cape that are part of this pilot of chicken livers, which are benefiting from the chicken livers program. Again, Chair, looking at the net impact of this program in the Eastern Cape, it has created employment opportunities for what you might call food handlers. And in this case, those who are appointed food handlers in the main meal, 12,000 of them are benefiting from the grant. Then those who are appointed in the breakfast meal is 9,791. So we don't benefit a handler twice. So what it actually says is that the 12,000 is not the same as 9,000. It's different people altogether. Then for the appointment of monitors, we have 54 monitors that appoint the program at large. That is the scope and scale. This is the cost. We are funding for 200 days, Chair, in a year in terms of the program, which is the academic days. And in all of this, we are including both the breakfast and the main meal in terms of what we do for this funding. For the allocation of food handlers, we are working on a ratio of the number of children to a food handler, and what we've done is to subdivide per centile, in fact per 100, between 51 and 400 we have 2 handlers, between 400 and 1, so in intervals of 200 we have a food handler that we allocate, and also the cost benefit of that. As the entire social cluster, there are specific programs that support us in what we do, and in all of these I should think I can probably talk about the emergency food parcels or food relief program, which is a 3-month program that is targeting the indigent families, especially when we have issues of crisis, emergency feeding programs as part of this, then food supplementation programs, which is also run by DST, but they are running in conjunction with us, as well as agricultural production and support program. There is also youth and women agricultural development, there's income support. But in the grant, we are collaborating with social development on these 2 main grants, the Child Support Grant and the Foster Care Child Support Grant, which are the main grants that seeks to alleviate and impact. And these are the numbers in terms of beneficiaries. So kids of school-going age that are benefiting from this is 1.3 million in terms of the Child Support Grant. But for the foster care, almost 200,000 children in the Eastern Cape are in foster care benefiting from this graph. Now, Chair, In terms of analysis and overview, we have been talking roughly on averages, but we have also spoken about the total number of learners that are impacted by these grants in the province. Thank you, Chair.
No, thank you very much for a very clear but also well-crafted presentation. Thank you so much. Acting DG, any further from yourself?
No, Chair, just to be clear about those two recommendations, the first two recommendations of the Commission. The first one is the extension of school nutrition to the ECD centres. Now on that one we have lobbied the Treasury, we've gotten an allocation to pilot the extension, and that work has started. As Mr. Ndlovu has indicated, we specifically interested in piloting in the Eastern Cape. The second one that I just want to emphasize is the extension that the Minister of Finance has just announced in the budget that finally got accepted, the extension of the subsidy. So the subsidy has been 17 Rand for probably a decade. And the first time, 2025, that subsidy has been extended to 24. It increases the allocation for nutrition support from around 6 Rand 40, which is what we've been working on, to about 9 Rand 60. And as Mr. Ndlovu has indicated, we've now finalized a menu for ECD centers that we are consulting on with civil society. In fact, on Monday for the morning, we had a discussion with civil society partners about finalizing that menu. So I just thought I wanted to emphasize the 2 points that Mr. Ndlovu made. Thanks, Chair.
No, thank you very much, Acting DG, as well as your colleagues. We very much appreciate your presentations, and it's quite clear that you are responding as well as you can to the implementation of our recommendations, given, of course, the existing and continuing challenges, but it's certainly clear that there are improvements. Thank you so much for that. I'm going to hand over to Dr. Carter and thereafter Commissioner Makwasha for questions.
Thank you so much, Chairperson, Commissioner Makwasha. Thank you so much to the departments for the submission. Number one, just an acknowledgement of the success of the National School Nutrition Program in South Africa, the acknowledgement that this is probably the most effective poverty alleviation and assistance mechanism to children, and assisting hungry little ones with at least in most of the country with 1 meal a day. It is commendable, and it's certainly one of the best programs that have been rolled out by government. So thank you for that, and thank you for championing this, because it certainly changes the lives of children. That being said, just a few questions from my side, and thank you. I think, Acting DG, you did clarify my questions about the data or the funding submissions that was provided, because my understanding is the pronouncement was made in 2019 already that ECD will be moving from DSD back to education. And in 2025, at the end of 2025, we are talking piloting a program. My concern is if we're looking at ECD, this is exactly the portion of the children's population that we are missing when it comes to nutrition, because the bulk of them would be receiving the NSNP through enrollment from grade R onwards. The CSG would cover both children at home or in ECD centers and at school, so they would have 2 levels of access. But the ones in ECD centers and which have not reached your schools yet are without. And that is why the Commission was very clear in its recommendation, not only to you, but to DSD, to National Treasury, that we need to look at this missing portion of children. And we need to look at them very urgently so, because again, we've heard about the first 1,000 days. Again, we know that severe acute malnutrition affects the smallest little ones, most grossly so. Now, my concern here is, and I recognize the efforts that have been going into this. I have to underscore that we are not moving with the speed that is required. Because if we look at the pronouncement at 2019, and we are at 2025, that one child would have gone past the ECD stage fully, and now would be in school if that child made it to school. Now, my submission to you is how, and I'm very thankful that this pilot project would in fact be rolled out in the Eastern Cape, because that is what we need. And I hope that our push for this can be very strong. But what about the other children? We are speaking about a pilot, and a pilot means we are only starting to see how we're going to do this, and whether it's going to be successful to be scaled nationally. Now, this morning, to the colleagues who did not attend this morning's session, we are looking at a death of 18 months, 1,000 dying from severe acute malnutrition. And that number is certainly something that has to have us sit up straight in our chairs. And we already heard the DG from DSD saying we need to think outside of the box. So DG, mine is just to ask, what are the timelines we are looking at here? What is the pilot timelines? How long until we're going to roll out the access to this NSNP very successful program to, in fact, the most vulnerable learners and the most vulnerable kids that should be receiving this? And perhaps my plea is, can it not be business as usual? The pronouncement was made in 2019. It's 2025. Certainly we can't be speaking about piloting. Thank you, Chairperson. Sorry, I was just thinking about the piloting. Just the last question I do have. Once this is rolled out, is it only rolled out to ECD centers that are registered? And the follow-up question to that is, we know that learners have access to education even if they're undocumented. These learners would also be in ECD centers, more specifically so because of late birth registration and processes ongoing. Will this be extended to learners who are undocumented as well, not only unregistered ECD centers, undocumented learners at ECD centers? And do we have the numbers of undocumented learners currently in schools? And is that taken into consideration when the department funds the NSNP? So those are my questions. And if we don't have the numbers, are you able to provide the Commission with the updated numbers specifically for the Eastern Cape as well? Thank you.
No, thank you. Thank you, Dr. Carter. Acting DG, let me hand over to you to respond to those questions before I hand over to Commissioner Makwasha.
Okay. Thank you very much. Thanks for those questions. So the pronouncement was made in 2019, but the actual transfer happened on the 1st of April of 2022 from DSD to basic education. The first thing we did, Chairperson, was to better understand how, what the sector looks like. So we did an audit of ECD centers. In terms of that audit that we published about a year later, there are 240,000 ECD sites, 242,000 nationally. I unfortunately don't have the numbers for the Eastern Cape, but certainly we can provide that. ECD also use a range of modes for implementation. So you could have one of the first things that we did when we wanted to start this pilot that I referred to was to visit some of these sites. In some of the sites you'd have 5 children. In some sites you have, we were visiting the Western Cape last week, looking at the provision of nutrition in these centers. In some of them you would have 10 children, but they would come for an hour and they would play and they would leave. And so part of what particularly I want to understand is how do we provide nutrition in that context? Because essentially, the first 2 years remains the responsibility of the Department of Health. I hope DG Health explained that. So from 3 to 5, they really come into the ECD centers then where we look after them. The ECD centers are also economic opportunities to communities. There are mamas and women and men that run these for profit, and that's how they make a living. And so what we wanted to do when we took over the sector was to say, let's not schoolify. Let's not make them into schools and bring all of those children into centralized centers and then remove the opportunities, because the practitioners often don't have the capacity to become teachers. They dropped out of school when they were grade 1 or grade 2. They've done it forever. They love the children. They make a huge contribution, but at 55, you're not going to get this person to do a matric and move on to be. And so you've got to look at that separately. You have to look at it differently. So when you talk about thinking out of the box as bureaucrats, which you know is difficult for us, we literally have to think out of the box for ECD, because it is so different from what we are used to. The one thing that we've done, because what really worries me is that if you look at the Thrive by 5 study that the Minister released on Monday, it says that stunting rates for children in centers, so they looked at children who are in the ECD centers who's coming into some ELP, early learning program, and at children that are not yet enrolled. And I'm sure you know that probably the bulk of 3 to 5 year olds are not yet in centers. And so that's what the Banapele drive, currently is about. So in center, 7% stunting. Out of center, 18% stunting. So centers make a difference, and it's probably because they have access to the subsidy. What we've done, Chairperson, to enable us to do the pilot for those children that probably most need it, is to give those centers provisional accreditation, or registration, if you like. So the Minister's introduced a kind of a robot system. They call it bronze, silver, and gold. So gold are the existing ones. They benefit from the subsidy. So they get those subsidies every month, the 24 Rand. The silver and the bronze do not yet, but because they often don't meet the infrastructure requirements. And so here's the conundrum, because you would go to a center, it's an ECD center. When you get there, they say you park in the middle of nowhere, and there is a hairdresser with lots of people, milling around. And you say, but I'm here at the, in terms of the address, they say, yes, it's you at the right, come through. Then you walk through the hairdresser with lots of noise and people and drinking and all sorts of things. And right at the back, there's a tiny little shack, and there's 15 children sitting in there. And so for the state to give accreditation to such a center is very, very difficult, because it is a risk, and you can see that. But it is all that the community can afford, and there's a person who's willing to take care of the children whilst parents go out and work. And so what we've done, Chair, to allow those centers a minimum form of registration, we call it bronze registration, and we can now roll out the program in those centers. In the Eastern Cape, and just is completely coincidental, I just looked at the numbers this morning. They've got 650 centers that have attained bronze status. And so it's probably in those centers. So we'll have to, I know Mr. Ndlovu said we were thinking Matatial, but we'll have to look, and maybe in the end it'll be a combination of bronze and silver registration status centers where we can then roll out the program. So this missing portion that you're referring to is what what we are trying to reach. And it doesn't mean, of course, those children benefit from the child support grant. And of course, if 5-year-olds are enrolled in grade R, that now in terms of the passing of the Bella, they would now come into schools. In fact, last week we spent some time with the Treasury having costed grade R. So we're saying 5-year-olds, if you are in school and you're in grade R, you will benefit from NSNP, and the Treasury has agreed that they will extend the NSNP to enable us to do that. We're doing both food and, like Mr. Tewakari was saying, to also cost the food handler component. So why do we need the pilot? Because we need to understand what it is that we need to provide. Now let me give you a few examples, Chairperson. I'm assuming that when you have 10 children and 1 adult, you can actually cook for them as that 1 adult. You can make the porridge in the morning. But there is going to be a point at which it's going to become difficult for one person to do so. I want to know, what is that point? Is it 20? Is it 30 for one? In schools, we, as again Mr. Tewakadi explained, we say 200 to 1. But in schools, we cook big pots. So one person stands there on a stove, it's a big pot, and somebody comes and dish from there. But in a ECD center where the numbers are small, we need to know what will work and what is safe. If you have one room, where must the stove go? And what is safe for those children? So there's a lot of variables here that actually we need to understand, and to understand them well. I also don't know if they have cooking facilities. Do I need to provide stoves like we do in schools? My assumption is that it's easier to provide refrigeration if it is somebody's private home, for example. But again, Chair, if it is taxpayers' money that we're putting into those centers, we want to understand. So the pilot will run for 3 years. The Treasury has made money available for 3 years. In those 3 years, what we want to do is, where it works and we can support the provision of food in those centers, we want to go back to the Treasury and say, in this center, in this area, it works. We don't want to continue to pilot. Let's run it. The other condition that we've given the Treasury is, we don't want to start in an area. So for example, if we start in Matatial, like Muzi has explained, then we don't want to start piloting and then in a month's time say, no, we actually don't want to provide the food here. So once we start, so it's also, if you like, it's a phased rollout for us. It's when we start, we will continue to, to actually roll it out. Undocumented learners are learners in our schools. It's accepted, it doesn't matter, they're part of the, at least for NSNP. They get their workbooks, their textbooks, teachers, we provide food. I don't have the numbers, I don't know, maybe Ray knows the numbers for the Eastern Cape, but we do actually collect the statistics, both for NSNP and for other reasons, and we can make those available to the Commission. Thanks.
Can I add, Chair? Probably in our case, we also have court rulings on undocumented learners, the right to transport, the right to food and all. So it's something that we had to take care of because there was a court ruling. However, what we did in our case was to work with Home Affairs, just to find ways and mechanisms of creating and generating IDs for these kids. So that process, we do capture the data of where the kids are, the schools, because we link them to the MIS number of the school. And then we group them per district, per circuit, per school. So if the Commission wants them, we can pass over. Chair, I just wanted to say, Chair, something that is encouraging in the discussion, Doc, is the direction of the narrative. Yesterday, we were discussing a court order by Kula Foundation on the right for learners to access scholar transport. And in this case, we have money or not transport learners. However, in the court order declaration, they said if you agree amongst parties, you can come back to the court if you have mitigation circumstances. Now, all the time we've overlooked the matter of the court giving us that opportunity to relook the narrative. We then felt that, look, it's undeniable there's a justice issue here. You cannot deny. You know, children, they have a right to education, they have a right to nutrition. And so there is, you know, a human rights issue. You can't run away from that. However, do you have an explanation of how you are dealing with it? Which is where my appeal to the commission was that, given what Dr. Whittle is saying, is that we have put in place a process to deal, especially with the missing middle. All of these children, the missing link. All of these children, we have a plan of how we're going to deal with them. And if the commission is patient with us in terms of the plan, even if probably Granville, we can pull together the plan, present to the commission that this is our plan over the next 3 years, then we can discuss and negotiate on the basis of achievability of that plan. Otherwise, I do want to appreciate the fact that you listen to the fact that we have a plan. We do acknowledge that this is a human rights issue and we cannot run away from that fact. But then we have to put it on the table for discussion to see how best we can handle it and how best you also perceive the feasibility of us achieving, you know, the objectives of that plan. Thank you, Chair.
Footnote, we were amicus on your Kula matter. We were in your court proceedings, so we are fully aware of that decision. But thank you for the reminder.
No, thank you so much, colleagues. Smalkolo, did you have something to say? I thought you were... Okay. Okay, no, thank you very much, colleagues. I'll hand over to Commissioner Makwasha.
Thank you so much, Chair of the Subpoena Hearing, Commissioner Nduli. I think for me, it's going to be two very clear questions. I think a majority of the questions that I had for the department have been asked. I'm looking at the report and I'm also looking at the documents that were shared with us. It says that, one, there was specific recommendations that were made to the National Department of Basic Education. I just want to follow up whether or not, and it says investigate the possibility of expanding the NSNP to include weekends and school holidays, providing consistent assessment to access to meals for vulnerable children. And I noted that you said you only provide meals only 200 of the 365 days. Have you investigated this possibility and what is the outcome? And then to the provincial department, there was that issue, and I think Dr. Carter, you asked on it, but I just want to expand on it. The issue of unregistered ECD centers. Have we received that list in the 39 identified wards and outline intentions to support them with conditional registration, funding, and assistance to meet the required norms and standards for operation? And the reason I'm asking the province is that, you know, you mentioned it, that often what happens is it's a shanty where 10 children are staying there. They're paying about 50 Rand just so that. Have we tried to assist them to meet the norms and standards? And if they are unable to, something that we have been emphasized as the Commission, are there alternative methods to meet those norms and standards? For example, looking at the use of alternative energy and looking at perhaps bringing back cultural ideologies into early childhood development centers that perhaps we could interrogate and then look at the resources and build on that, instead of saying we don't have the financial means to provide them with the fridge, but we could then have this. I'm thinking about a communal way of ECD centers. Perhaps you identify a region and then say, we'll provide warm meals to these centers, and then they will distribute. So creative ways of looking at the problems that we have, because we don't have currently the financial resources to immediately, in terms of Section 28, provide with an immediate solution. Thank you.
Over to you, colleagues.
Thank you, Chair. Probably just to go back to what Dr. Whittle was raising, that the institutional mechanism was always to be a flexible, open mechanism. In some instances, these learners are attached to a formal school. In other mechanisms, it's play groups. In other mechanisms, it's home-based. So that's what we're trying to manage. So we've never thought about bringing them under one roof, under one room. However, what it does, the current provisioning framework, is that it allows you to have the maximum number of children exposed to a learning program. We always run away from saying, as education, our core business is to make sure that they can learn, but we acknowledge that they cannot learn in an empty stomach. And that's where we're moving from. So in these play groups and in this home-based care, whatever solution we find, we are never trying to do away with that institutional framework. We always wanted to provide within that institutional framework. So that's why Dr. Whittle is saying in the piloting, we want to look at what are the responses to the institutional frameworks that we find given the stimulus that we're going to throw in there. So we want to look at the reactions, we want to look at the frameworks that emerge. So I should think so far we had thought that the piloting will be designed around that institutional arrangement. But if it then requires a different arrangement, then we'll have to do that. Because any social phenomenon is a living phenomenon, it keeps on changing. So, however, in this instance, we really wanted to see whether we can encourage an open learning system, particularly in that age group. Now, when we look at it, at times I think initially we were blinded by the fact that our responsibility is to basic, from grade R up to grade 12, then below that, subsidy formula and all. Now, the report on malnutrition brought it back to our doorstep that we are equally responsible for that grouping, including the quality of the curriculum, the quality of food. So that's why I had thought that the recommendation by Dr. Whittle that we will be piloting, it can give us an opportunity to look at the frameworks as well. Are they responding very well? Right now, what we have not tested is the impact of the social development grant system on the homes that are running with these kids, your child care as well as the child grant. No, we haven't been able to look at the sum totality. That's why sometimes you get a sense of double dipping without impact. And when we do this pilot, we want to link the real home address to the number of grants received by that home, and therefore the impact of what we do to that income. So it's really a complex, kind of structure that we want to bring together, and that's where we are with the piloting. That's the construct that we're trying to pilot. Thank you, Chair.
Chair, the issue of weekends and school holidays is a very difficult one. I mean, I think our approach is that government probably should find a mechanism to do that. It's probably not to be done through the basic education system because of how we're structured and how we operate. In schools, we've got 200 school days, and we provide 10 million children at the moment, 2 meals a day. Our allocation is 10.3 billion rand. In ECD centers, we're working on 260 days. Right, so our intention certainly, even though, in the discussions that we had on Monday, some of our civil society partners were explaining to us that ECD centers, unlike schools, don't really open in January. Because some parents, stay in the village, take a bit longer to come. They migrate at the beginning of the year because of economic opportunities, etc., etc. And so those are things. But we do accept, Chairperson, that in ECD centers, we will provide nutrition, and we're budgeting accordingly for a much longer period of time. It might not be weekends, but it may include school holidays. If those learners come during a school holiday, we will provide. But unfortunately, our budget and infrastructure do not allow us to feed during school holidays or weekends. Thanks, Chair.
Yes, yes.
Apologies, Chair. You just triggered something that you had asked about the using of school land to then farm food, and we could then resolve that issue that they're saying that we don't have the budget to provide for weekends. We could work collaboratively that we will use some of the school fields to have multiple crops. I know, I'm thinking about my home village. There's a massive piece of land. It's a remote village in Limpopo where they're no longer playing soccer. You could utilize it just to primarily say, this particular school, we're going to give you seeds to maize seeds, and you're going to do that, but you're going to exchange it with the next school so that the schools are changing crops so that it's not just, I know I'm going to expose my farm history, and Commissioner Ntuli is a farmer, so she will then expand on it. But I think that's the creative way that we're looking for, that you don't have to spend a lot of money. You can just start then. It also teaches children responsibility, and it can be part of the ELO project. And I remember when I was in primary school, we did the bean project, and you grew your own little bean. So I think maybe we could do it that way, creatively looking for solutions. But going back to the pilot, and my concern is the one shoe fits all narrative. Now, while we're going to pilot it out in Eastern Cape, there's specific societal concerns that would impact Eastern Cape, but not affect KZN and not affect urban areas like Gauteng or provinces like Gauteng and then these other provinces such as Limpopo. I propose that maybe we look at, and I know the budget constraints, looking at piloting it out in maybe 3 provinces and collecting data so that you don't have to now readjust it for the provinces when it's time to roll it out. It's a proposal.
No, thank you very much, Commissioner Makwasha. Did you also have a follow-up question?
Just not to develop this into a think tank, I do apologize. But hearing Commissioner Makwasha, and she's also responsible for business and human rights, hearing the fact that many of these very small sites need support just to amend here and there infrastructure issues. Has there been opportunity for business to come on board? If we speak about the 39 wards we know are so vulnerable in terms of the malnutrition crises, whether the ECD centers with a rough outline of norms and standards for infrastructure for ECD centers can be developed also as a pilot so that business can come on board to say, listen, we can in the 39 wards, we roll out the pilot project to support ECD centers in the 39 to, in the bigger picture, have them a little bit more aligned to norms and standards of what we do in education, but creating a little bit more of a rough model for these centers and just getting business on board to assist us, because we know the fiscus is not going to allow immediate implementation for quite some time. Although, I'm going to go back to Section 28 and remind everyone, we have a responsibility for immediate enforceability. Thank you. Askies, again, my chairperson.
No, it's fine, PM. Please go ahead. Please go ahead, Acting DG and colleagues.
I hope that's on, yeah. So I was in the room when Chair made those comments about the school gardens. Now, school gardens, probably 10 years ago, we had food gardens as a pillar of school nutrition. But we really, really struggled to successfully implement it. We even had a budget allocation. And part of the difficulty is that, climate change is hitting many parts of our country. In the Northern Cape, I can tell you, it's very difficult to sustain a food garden. That area around Uppington, it's almost impossible. And what we've also learned is if you have a dedicated adult at the school that leads, then the garden thrives. I mean, I can take you to absolutely stunning food gardens Mr. Ndlovu and I last week in Cape Town in Tafelsig. You know, it's one of the most gang-ridden, violent areas that you can find on the Cape Flats. But they've got a lovely school garden and a gardener that was very proud to show us around, you know, what they're doing in that, and fantastic. In a little town called Robertson in the Western Cape, they're able to not only grow their own vegetables, but they actually supply to the local fresh produce market. And the principal grows enough to give every family a bag of vegetables every Friday. So wonderful. They really are wonderful initiatives. And the private sector, and you know, if it's fine, I'll mention the two companies, but two very corporates in South Africa currently working with us to encourage schools to grow their own food. In Soweto and Gauteng, in Umlazi, in KZN. So there are really good examples of that. But what I was worried about 10 years ago was the extent of worms that our children are facing in schools. And so what we decided to do at that time was to redirect the funding that we had for gardens to a national deworming program. We currently, Chair, we deworm all children in primary schools once a year. We have even worked with the WHO. We've done a mapping of the country so that we know where we have the biggest problems. Our challenge at the moment, and I was saying this to the Chief Director, is our challenge now is to extend to ECDs. Because previously we relied on the Department of Health to do it, but since it's now with us and the tablets are allocated to us, it's a challenge that we will take up. Remember when we do HPV for the grade 5 girls now, we also do the deworming in those primary schools. And initially, we had lots of resistance. We had Parliament calling us to say it's toxic and all sorts of things. But 10 years later, teachers accept that they hand it over to the children. It comes at a very low cost to the state. And we do about 7 to 10 million children every year. The challenge is to do it in ECDs. So it's really an opportunity cost for us, where you have schools committed to do this, the food gardens. We support as much as we can. In Mpumalanga, they will even give you a gardener if the school is committed to doing so. But we don't formally support food gardens any longer. The issue of business is a really tricky one. When we didn't provide breakfast on the school program, on the NSA, lots of businesses supported breakfast in schools. The minute we introduced it formally and funded it as the state, businesses moved away from the program. I suspect, thank you, I suspect, so what I'm saying, Chair, is we obviously want to hold on to the funding that is provided by business. ECD, and I because I'm under oath, we can check the figure, but the last time a colleague was telling me that they get about 7 billion a year coming into the ECD space from the private sector. So what do you want to do as government, as the state? You don't want to lose that funding and then dip into the fiscus, to cover that. So the challenge that we have all the time, particularly when it comes to the provision of food or, nutrition in schools, is to try and find a balance. You don't want to say to a corporate that's willing to give it to you that, stop doing that because actually we can cover it from the fiscus. You want to continue to work with them. And so at the moment, that's the kind of balance that we're trying to strike. Eventually, as the state gets up and running, the budgets become available, we've built a system like we've built for school nutrition. Then of course you can go back to corporates and say, well, cover something else. as the need evolves, maybe move on to something else. But for where we are now, where we don't yet have the budgets, and there are many corporates who are donating, supporting nutrition in the ECD space. And it is a bit of a balancing act about how you don't push them out, because you want to retain the expertise and the resources that they bring. Thanks, Chair.
Yes, probably something interesting is the model that we also tried to start in the Eastern Cape, which was spearheaded by the Eastern Cape Socio-economic Consultative Council. We were trying to link up with Dr. Da, which is Department of Agriculture, on small-scale farmer development, which is part of their programs. And our view was that you can leverage food hubs through small-scale farmer development projects, where you create food hubs, supply to schools. I mean, currently most of our schools, because we transfer money directly to them, they buy from SPAR and all of this, and there is not necessarily any return on investment in that sense. So we were asking the Department of Agriculture to invest in small-scale farmers. Where there is land, we're prepared. I'm talking about school land. We're even prepared to say, look, we can use school land available in abundance to start the pilot, because our interest was whether we can create a food hub that will make food abundant to all children in the Eastern Cape. At the same time, getting something to the small-scale farmers, for the produce that they produce. Our biggest disappointment was the reluctance to uptake from agriculture. And I'm telling you, for the past 5 years, I've been knocking on their door just to see if we can really put this model into piloting stage, whatever phase that we could. Otherwise, there were such attempts, looking at, capacities of government, economic development, Department of Agriculture, just to see if you can collaborate around it. But so far, I don't think there's been an appetite, from these other departments. Thank you.
No, thank you very much. I'm pleasantly surprised to observe that the two gentlemen who were almost not sworn in are the ones who are most helpful, not to say the two are not, in our engagement. So thank you very much, gentlemen. We appreciate it. I've been substantively covered by my colleagues, but I do want to just ride on the back of the last submission that was made by Commissioner Makwasha and your responses, both of you. We have spoken about some kind of 3-year plan that you wish to submit to us. And I wonder if, given that we are all on the same page, that this is a problem that does not need to be a problem. We have all of the resources, both in the public and the private, to be able to assist us in moving away from this as early as possible. And I'm also quite inspired, Acting DG, to hear you emphasize, one, the recognition that it is difficult for public servants, bureaucrats to think out of the box, but it's also highly possible, especially when we work in a multi-sectoral environment and we take a multi-sectoral approach. Given the work that you're already doing with the private sector, given the initiatives that have already been started, of course acknowledging that there has been a slow and reluctant uptake from the Department of Agriculture, could we not resuscitate those efforts as a means to attempt to address this? And the Human Rights Commission would be more than happy to join in such an initiative. Land that's available schools have children that are hungry, and you've got in these communities willing potential small-scale farmers. If not, you've got educable, unemployed youth who could be trained via a partnership with the Department of Education or even the private sector, nurseries and other farmers. So the possibilities are endless, and the resources exist within us to be able to make into reality an end to this problem that is not a problem. So perhaps the challenge we could put to ourselves, acting DG and colleagues, is let us begin to work on a plan, and the Human Rights Commission is happy to support this plan, where we re-invite and reintroduce it is a matter of culture, a culture of self-sustainability, self-reliance, and automatically through those processes, we are also teaching the children that if you want to eat, you don't go to the shop, you go to the earth. And they grow with that culture. So by addressing this problem, we are addressing a much longer term national cultural problem that we might have. And this is the challenge that we may wish to leave with you, that this is a possibility. We are very much availing ourselves and happy to work with you on this. Let us try it, and let us come back together a year from now and look back and say, within a year we were able to address this. And all it needed, ADG, was just for us to think outside of the box and to work together. So that is the challenge that I would leave you with. And once again, thank you so much for a refreshing engagement with yourselves. Quite clearly, we have many challenges as South Africa, and as I stated earlier, it's not just an issue of hunger and food. It's the multiple intersecting crises that are coming together and making it very difficult for us to think about one problem without thinking about the other problems. And certainly they need us to think outside of the box in order to be able to fix them. So with that, colleagues, once again, thank you so much. I'm going to give you the opportunity to give us your closing remarks, Acting DG, and thereafter I'm going to hand over to my colleague, Commissioner Makwasha, to give us the closing remarks for the day, and we will adjourn for the day. Over to you, ADG.
No, just to say thank you so much. And I like the challenge. So yeah, we'll think through it. Thank you very much, Chair.
Thank you so much, Chairperson of the subpoena hearing. Once again, colleagues, today's proceedings have laid bare both progress and persistent failure. We heard from the Department of Health, the Department of Social Development, and the Department of Education. Each has outlined initiatives undertaken, and we note that there has been some progress in addressing malnutrition as a human rights violation affecting our children. Yet these three departments point to the same resource constraints. 3 years after the South African Human Rights Commission released its report, we are told that only 9 lives have been saved in this province. This is not a number to be celebrated, it's a constitutional crisis. 9 children under the age of 5 still died from malnutrition. This means 9 families bereaved, 9 lives lost to preventable hunger, 9 failures of the state's duty. As we close with the principle that echoes both our constitution and our cultural wisdom, Bana Pele, which means children first. Until we truly place children first, in action and not just in words, our work remains unfinished, our accountability remains in question, and our constitutional promise remains unfulfilled. Thank you, Chair.
Thank you very much, Commissioner Makwasha. Colleagues, thank you for your time once again. You may be excused, and of course it's not the end of our engagements. Acting DG, once you do have the plan, we would be most pleased to also see it and have the opportunity to make inputs if there are any. With that, colleagues, we are adjourned for the day up until tomorrow at 9 a.m. Thank you so much.